Thank you everyone for joining this wonderful webinar organized by Professor E.T. So maybe without further delay, maybe shall I invite Professor E.T. to introduce this webinar, and then we can invite Professor Carlo to make the opening speech for this special webinars. Professor E.T.
Thank you for your introduction. Good morning to everyone in the time in Thailand. So this, I would like to say thank you to Professor Yoko Kato, the president of Asian Congress of Neurological Surgeons, or to have give a big opportunity for me to be a host or the president in my first time about the webinar for ACNS, Endovascular Neurosurgery and Interventional Neuroradiology webinar seminar. So for the purpose of this meeting, we would like to introduce about the popular issue or the hot issue for neurovascular treatment in the current era, about endovascular treatment. And I about the young neurosurgeon or young radiologists who who interested about the treatment about the neurovascular disease by endovascular to join, because in this seminar we have many famous professors around the world to give about the very common or very specific topics. I hope this meeting can provide about the knowledge and about the trick and techniques to treat in neurovascular disease and improve about the outcome to the patients. Thank you for our professor and our attendant about this webinar. Thank you.
Thank you very much. So hi everyone. So good. Japan is just 1 o'clock. So good afternoon, everyone. So thank you very much. So this is our first trial of the endovascular neurosurgery and interventional radiology webinar. So I think for awareness to learn, it's a trend to learn both. That means it's a hybrid neurosurgery. It's very important. So in Japan, Professor Nakahara is the leader of the Endovascular Society. And I think many countries abroad, I think treated by the radiologist. So I think that is another high barrier we can overcome. Because the young doctors want to do the endovascular, but they cannot because all controlled by the radiology department. So, but I think in a day by day, I think for awareness must or can do the endovascular treatment. It's really good for the patient, but very, very less invasive. And sometimes they can go back the same day sometimes. So we are very much looking forward the super challenge of the world endovascular neurosurgeon will talk. Thank you very much. Sensei, congratulations. Yeah, leadership and the presidency of this meeting. Thank you very much. ありがとうございました。
Thank you, Professor. Thank you so much.
ありがとうございました。This is mute.
Thank you very much for the introduction, and thank you, Professor T, for organizing this really wonderful event. So, shall we proceed to our first speaker, Professor E.T.?
Yes, for first speaker today, I welcome Professor Ethan Last to talk about the use of fusion image in the angiosurgery. Professor Ethan Last, now he is a professor from Interventional Neuroradiology, New York University, Lagoon Health. Please, Professor, give your talks.
Hi, good evening, good afternoon, everyone. Thank you so much for the invitation. I'm trying to share my screen. Okay. There. Do you see? You should be able to see the screen, correct?
Yes.
Okay, it's an honor for me to be here and to be the first one to present tonight. Thank you for allowing me to speak in a time that is good in New York. It's just 11 p.m. here. I'm going to talk about fusion imaging and the importance of that in the Angio Suite. And this is a part of my team. Dr. Nelson, Max Shapiro, Erez Nosek, and the rest that you read here. And obviously, whatever I showed you is the result of our group work. The fusion concept is something that we're all very familiar with, and we use every day in the Angio Suite. Whenever we do a 3D DSA and we produce such an image, we're using fusion. We're fusing two volumes, and we're giving each volume a different color. And here, the bone and the subtracted vessel, we're giving them different color. But how about trying to bring this concept a little forward? And we thought about this a few years ago, and we developed these sort of images, which are relatively simple to obtain. But essentially, we get an arterial phase, and we get separately a venous phase, and we share them, the subtracted view. And then we create a sort of like fuse the arterial and venous phase, what we call the arteriovenous 3D DSA. What's the utility of this? It turns out, it certainly has some utility in certain very specific situation, but that was like developed very good images. I mean, aesthetically very good images. Certainly, like relatively limited clinical use, but that led to then the use on other clinical applications, such as in this patient with arteriovenous malformation, like cortical, sort of like frontal arteriovenous malformation, with two territories supplying it. One from the ipsilateral ICA with a very large MCA, and contralaterally through the ACA. So what if we get the two separate 3D and we give a different color, and that's what is done here. One we give a red color, one blue, and then we fuse them. And then by fusing them, which is essentially what Professor Chapeau talked about when he presented as 6D. This is the fusion of two 3D DSA. While despite these images, the volume rendered images are very, very catchy and very beautiful, it's really like with the cross-sectional one that you get to understand a little more about the AVM. So let me show you some example of that. This is another AVM, more like a posterior fossa AVM, in which you have supply from bilateral vertebral arteries. With the right vertebral artery only, you see selectively the supply from the pica, while with the contralateral, you see a supply from the SCA. And then you see this sort of like venous outflow. Now, it's very hard to understand exactly what's going on with the supply to this part of the AVM and so forth. And by doing these two separate, like 3D DSA and then fusing, you get to understand this much more. Because once you do that, you see that the venous outflow, the finest venous outflow, is sort of like shared by two components of the AVM. And to put that into like thick MIPS, which are really like the best way to really like understand these sort of images. And it takes quite some time, and it's almost like goes beyond our 10 minutes that we have tonight to share together. But really, like, you spend a lot of time by looking at this fusion imaging, and you get to understand really like how is the compartment of the AVM shared by the two territories. And here, for example, you see that whatever is yellow, it means it's shared by the two territories, and whatever is green is only one territory. Whatever is red is only one territory. So you get to understand what is shared by the two territories, and to put that together like in a more like anatomical image, you have this one from the right vert, you have this image from the left vert. You see that the final outflow is the same, but if you look and compare to this, you see that this is supplied only by the right side. This is supplied only by this part of the knife, supplied only by the left vert, so by the SCA. While these represent the start of the final venous outflow. So understanding these features of the AVM can really lead us to a better plan in order to exactly what to do. This is another example of the application of this imaging. Same thing, 2 territories supplying this large parietal AVM. And so in this case, we did 2 separate, 20-second DynaCT on an RT-SKU. And, despite the imaging being very good looking, as they obviously are, it's really what about the utility of these? And the utility is really, again, as you see here on these MPR images, understanding what's the share supply. And when you stop, for example, on this particular image, you see how there is a particular vessel here, which is yellow. Why? Because it's supplied by both territories. And these are the vessels that are important to embolize first in order to prevent essentially a refilling from the other vessel later on. Another example of application of fusion imaging on this patient with a flow-related aneurysm, with an AVM, a flow-related aneurysm that it has rupture, is associated with a hemorrhage. So we decided to embolize, and these are the images before embolization, and what we ended up doing, injecting glue. And this is the DynaCT post glue embolization of that distal lenticular striate supplying the pseudoaneurysm. And then we essentially fuse the pre-op imaging with the post-op with the glue cast, in order to prove really how we get the glue to the level of the aneurysm. So this is another example of application of fusion imaging. How about MRI? MRI and DSA fusion, I predict is going to be a big thing in the upcoming year, because as of today, it necessitates a lot of work with software. So if the companies would provide simpler way to make this fusion, I think we clinicians will use it much more. What's the role? The roles are in cases in which the AVM is not visible on the MRI because it's very small. So then if we fuse the images from our DynaCT or our 3D DSA, we can show it anatomically compared to the rest of the anatomy. And it's going to help really much with the choose surgical approach and understand really anatomically where is the AVM in terms of understanding the relationship with the eloquence of certain locations. This is a video. I'm not going to play the whole thing, but it's a video that shows how to do that on Visage, which is our current software, and it necessitates quite some work. But this is the final result, in which you see you can see the AVM superimposed on, in this case, on a flare, and then you can really understand that much more detail. And these are final images from that, and you can play with that. But how about clinical application? And this is an example of that. Okay, patient comes for a gamma knife. Why? Because they had an AVM before but had residual, and come for a second stage. The day of gamma knife comes for angiogram, and we see very clearly the residual little AVM with the early venous outflow. Okay, and then goes for we also get the 3D imaging to better understand the residual nidus, and then goes also for MRI together. The MRI shows this area of enhancement that initially is thought to be the AVM. But it's just with fusion that we prove that's not the case, because by fusing the two, by fusing the DynaCT and the MRI, we show that actually the area of enhancement is not the area where the AVM is. The area of the AVM is much higher, is just adjacent to it. But this sort of correlation can make much more precise the application of the gamma knife. Now, another application that I'm particularly passionate about is this one. As you see, this is a very beautiful image showing in very much detail pipeline embolization device construct in relationship to an aneurysm that we treated. What is this? This what we call it the super dyna. Why we call it like this? Because it's something that goes beyond the value of a subtracted 3D DSA. And why? Because it's created by using a DynaCT. So let me go through these. This is a particular technique that maximizes the ability to see both the device and the vessel. and overcomes the limitation of the other techniques, specifically with a 3D DSA. Usually the mask is not a very good quality, and you see very well the vessel. Vice versa, with a DynaCT without a mask, usually like you cannot really separate the device from the vessel. And so if you're interested about it, I recommend to read the article, especially the supplemental material. It really goes to the detail of how to obtain this. Now, it's been previously described. This is not new, and there are a few groups that describe the application of this. And so I really commend these authors for having described it earlier. It's not the machine dependent. It can be done with any machine. And essentially, you get a 3D DSA, or like using getting a subtracted volume. But then you also get a sharp reconstruction from the highest resolution imaging that you can get with your machine. And then you fuse them, and then you get this sort of like very, very, very good image that can lead to some understanding. And I'll go through that in the next couple of minutes. This is the example of subtracted 3D DSA. This is the device, very, very high resolution device image, and this is the fusion. Okay, so how about the roles of this imaging? Evaluate landing zone. To be very precise on understanding landing zone, for example, in this case, we want to make sure the device didn't cover at all the A1 segment, and proximally it didn't come to the curvature of the cavernous segment, so it showed very well the landing zones. Or in this case, in which there were two aneurysms, like an ophthalmic and a choroidal aneurysm, we wanted to make sure that we covered both without jailing the terminus, and this is it. The application of this image shows very well how we covered the aneurysm and we got to the terminus without jailing the terminus itself. It also shows, in this case, the same case showing the terminus termination. Here, in another case in which we wanted to show in this PCA that this branch was not jailed, and this is another example of the application. Or in this pica aneurysm, in which the device was placed very, very precisely at the origin of the pica without having it navigated all the way to the vertebral artery. This is another case of a terminus aneurysm in which there was a lenticular stride coming from the MCA and the choroidal, and we wanted to try to prove how we could avoid double coverage or coverage of both. Not covering both was not possible because of the length. So we decided to avoid the coverage of the anterior choroidal artery. And this was the demonstration of that, how we had to cover one, and we decided to cover lenticular striate and not cover the choroidal artery. In this other case of a recurrent anterior communicating artery aneurysm after clipping, the application of this imaging shows how we could spare actually the jailing of this vessel, which is actually a vessel coming from the ACA, very, very important. In this case, is an important anatomical variant, which is the ophthalmic artery originating from the A1. How about evaluate the coverage? In case of multiple device utilization, the application of this imaging shows how we can selectively increase the coverage of the aneurysm neck, but keep the coverage of side branches low by overlapping only at the level of the neck. And this is an example. This is another example of a patient with a blister aneurysm, but also this other aneurysm. We're not 100% sure exactly what was the source of the hemorrhage. Very likely is this blister-looking dilatation. So what we did, we double covered that with two stents, and we single covered the rest, including the choroidal artery. And this image shows like the double cover at the level of the blister and the single cover of the rest. And so forth. I can go to this quite more in detail. One thing that probably one last thing, I have a minute more. One last thing I wanted to point out is how it leads you to a better understanding also of the failure. Look at how this resolution shows you the device. This is the pipeline device in so much detail that you can see like the platinum wire and the cobalt to chromium wires that are less radiopaque. And when we think of the reason why treatment may fail, there are a few reasons, one of which is even when you put multiple devices, there can be a random area of lower coverage that can just happen because of random reasons, even if you put multiple devices. And this is an example of a patient in which multiple devices are placed, 3 devices to close this ophthalmic aneurysm, but regardless, the aneurysm persists. And when we look at the details that are provided by this imaging, we see that the aneurysm persists because there is a demand of the ophthalmic artery, and this demand is filled through the aneurysm in virtue of the flow passing through a specific area of the stent. And if we look at this in detail, we see that all the flow passed through here. We look at it pass through here, and we look at the stent, there's a random area of lower coverage exactly in that spot. And that's why this treatment is a relatively failure because of that. The application of this image you can do also with other devices. This is an example in the web. This is a case of an MC aneurysm treated with web, and you see how even if at the first glance it looks very good, when you try to look at it in more detail, you see that there is indeed a neck remnant, here. So probably will need more treatment. These are other devices, Silk Vista Baby, clips, and so forth. So to conclude, fusion imaging is super helpful in many situations, especially I would say AVM, as well as the application of high resolution device imaging fused with 3D DSA to understand, generally speaking, is to understand, learn the protocol and apply them as needed. And thank you very much again for the invitation. And it was a pleasure for me to share our work.
Thank you so much, Professor Ethan, about the wonderful talks. Do you have any question from the audience or the panelists?
Richie, Anil is raise hand.
Yes, Anil. Please unmute your mic.
No, I don't have any question, but a very nice presentation. Thank you.
Thank you.
We don't have access to such image fusion as yet, at least where I am working just now.
Okay. I have to say that this obviously the more modern imaging machine are able to provide better images, but theoretically, fusion imaging is something that you can do also with not the last generation machine. I would say starting with the ARTIS, work with Siemens, so I talk Siemens language, starting with the ARTIS Z, moving forward, so ARTIS Z, ARTIS Q, and Icono, this sort of work is possible to do.
Thank you.
Thank you.
Sensei?
Can I ask a quick question? Professor Ethan, thank you very much for your excellent lecture and quite a very this valuation of the technology can really make the difference. I can appreciate that the usefulness. I want to ask about what device or what machine that you use. Is it a commercially available software or
yeah, this is all the work, all the images that I showed are actually not all. Most of the stuff that I showed was just created at the Siemens workstation. Okay, part of it, only the MRI fusion was done on PACS. It's a Visage, is the PACS we use. But the majority of the work I showed you is just done at the Siemens workstation.
I see, because it's certain for me to see that you can load the MRI and then fuse it with the DSA. I think in my unit I don't realize that we have this function. So very interesting.
So that's done with the PACS that we use. It's called Visage. It's I have to say it's not that straightforward. It doesn't work 100% of the time. Sometimes it's easy to register. Sometimes it's not. So we don't have a very easy way to do it. But you know, and that's why I think it's something that as a field, it's something that it's going to be a role more and more, because I think there's a lot of potential usefulness for that technique.
Yes. If you want to fuse the images, is there any minimum number of the frame per second for the DSA frames for you to fuse your DSA?
No, as
No.
long as you create a volume, then it's okay. So as long as it's a rotational with a volume that you get, that's enough.
I see. Thank you.
Thank you.
Thank you, Professor Ethan, for your valuable talks. Okay.
Thank you.
Thank you, Professor. I will invite to the next speaker. Okay.
Sure.
Yes. For the next topics, about the topic of for Professor Timo Kring. Professor Timo Kring, he is a professor of neuroradiology from Toronto Western Hospital, Canada. He will talk about the curative AVM embolization using a mini balloon, transarterial and transvenous approach. But unfortunately, today he have an emergency case, so he just record the video and send us. So we will present about the recorded video from his talk. Please, Dr. Ben, can you start it?
Sure. Can you see the screen now? The screen sharing?
Yes, we can see the screen.
Thank you.
Dear colleagues, I'm sorry that I will not be able to give you this lecture live, as I am on call and I was contacted for a case and I have to move into the hospital now. In the next 15 minutes, I will record you a lecture on curative brain AVM embolization using mini balloons. I have no disclosures in relation to this talk. Now, in my talk, I will speak a little bit about problems with prior approaches when we are talking about curative brain embolization. We'll talk about transarterial glue embolization, standard onyx, fill or squid, coil or glue-assisted pressure cooker techniques, and then compare these techniques with the mini balloon technique that I will propose in this talk, and we will talk both about transarterial and transvenous routes to use mini balloons. So when we're talking about glue has many advantages. Glue is thrombogenic, and especially in high flow or fistulous type of AVMs, we believe that glue is a very good option. So here we had one example where I thought we had more or less a single hole fistula. So we went ahead, did the glue embolization, but you can see that after the glue injection, there's still a little bit of filling here into the venous pouch. And we identified a tiny vessel that was coming more closer to the nidus, going here into the venous pouch. And we had to catheterize this supraselectively to then go in with the glue injection to completely then cure the AVM. Here we have the 3 months follow-up, and the patient did very well. And the 3 months follow-up on DSA with a complete curative embolization. The problem with glue, as highlighted here, is that in the moment where glue would reach into non-glucosed blood, then it would harden upon contact with blood, which means that if the glue would go through this channel here and be in contact with the non-glucose blood coming from here, then we would not be able to reach the vein. And therefore, one of the problems of glue injection is the possibility of an incomplete embolization due to additional feeders getting towards the nidus. What about other techniques? Here we have a patient who had an unruptured AVM, but he presented with progressive weakness related to this edema. And on the CTA, we see the AVM, and we can see that the cause of this edema was progressive venous thrombosis. Now we are here right now smack in the middle of the central motor cortex, and we really do not want to have reflux. And one of the problems with Onyx is that you can get some reflux here. This patient got lucky, he had no symptoms. Here's the 3 months follow-up with a complete cure of the AVM. But one of the problems with transarterial Onyx, squid fill, is that you often have a reflux margin. And this reflux can be, depending on what type of catheter you're using, up to 3 centimeters, which means that if there is a branch going towards normal brain tissue, then there's a risk for inadvertent embolization and a stroke. Also, one of the problems is when you're pulling the microcatheter, there will be traction on the vessel. And again, there's the possibility of incomplete embolization, especially since glue fill or the squid are not thrombogenic. So there's the risk for still having additional flow going into the AVM, and there's the risk of reflux, and therefore reflux into normal branches that may cause a stroke. So in order to prevent this, pressure cooker techniques have been described. Here's an example of AVM of the corpus callosum that we can see here. We see it's a monocompartmental AVM, single feeding artery, single draining vein, a nice compact nidus. We believe that these are good targets for embolization. And you can see here that we did a pressure cooker with coils and then a little bit of glue, dual microcatheter, having one detachable tip microcatheter here. There's a distal tip. And then you can see here nicely that the Onyx that we used in this case here only went into the AVM. We had no reflux and were able to have very nice dense cast of Onyx that led to complete obliteration of the AVM. This is the final angio. This is the 3 months follow-up on MR. And here's the 3 months follow-up on DSA with the complete cure of the AVM. What are the problems of the pressure cooker technique? You have to have at least 1.5 centimeter parent vessel occlusion. You do need to put in multiple catheters. There's again traction on the vessel. And for these reasons, we believe that maybe other techniques may be helpful. So we talked about the problems with the prior approaches. Now let's speak a little bit about mini balloons and their use in the transarterial and transvenous routes. The mini balloon that we have been using is the Scepter Mini that has working length of 165 centimeter. The distal tip is only 1.6 French wide. There is a tip length 2.5 millimeters towards beyond the balloon, and of importance is that there's no radiopaque marker. So whenever you inject Onyx through it, will actually come out more distant than where the marker is that is measuring the balloon. The balloon has very, very small injection volume, can go up to 2.2 millimeters, but with even smaller injection volumes, you can get like into vessels that are just 0.5 to 1 millimeter in size. Given the highly flexible material, we can get quite far distant into the blood vessels for the subsequent embolization. Of importance, and this is kind of a learning point, how to prep those mini balloons when you do put your syringe here onto the hub that goes towards the balloon. Do not remove it, because just the simple meniscus that you can have while putting the syringe onto the hub can be an injection volume, or similar to an injection volume, that will make your balloon increase from easily 0.6 to 1.2 millimeters, simply because the injection volume is just so small to open up the balloon. And there is therefore the real risk for parent vessel rupture if you do not prep the balloon correctly. Here we have a patient who had a previous hemorrhage. We can see very far distal AVM, quite tortuous vessel here. We have to go up and around, then go past this point, go again around this curve to get actually to the nidus here. So quite tortuous, quite far distal, but you can see that the septum-mini can do all of these curves quite well, and we have here a very nice distal position. Another advantage of the mini balloon is when you inflate the mini balloon, as we can see here, you will have better understanding about your AVM angi architecture. This is without the balloon inflated, this is with the balloon inflated, and you can see that indeed we are just in front of the AVM and are here very easily able to then embolize the AVM. And here is the final control. There's the onyx cast. Here is the distal vessel. The onyx cast, very focal, without having to go into other areas, no reflux at all. And here we have the 3 months control with the AVM being completely obliterated. One of the problems of the septum-mini is that if you inject the onyx and you start getting reflux, then the plug that you are building against like the mini balloon can sometimes be so strong that the mini balloon actually is being pushed back. This would necessitate further inflation, and this, of course, in pile vessels can be dangerous. So this is an important caveat when using the mini balloon for curative AVM embolization. Here we have a different case, a patient who presented with a seizure. We can see the occipital AVM with perifocal edema, maybe some thrombus here within one of the nidal outpouchings. And given the close proximity to the calcarine fissure, the surgeons were somewhat reluctant to treat this with open surgery, and gamma knife was felt not to be the best treatment option because it would take 3-4 years for the AVM to be cured. And typically when we have this amount of edema and an outpouching, we classically want to have a treatment of modality that is faster. So here we have the angiography. You can see here our distal course of the vessel. We can see the focal outpouching right here. We can see that we are with the septum-mini just in front of the AVM nidus. We inflate the septum-mini, and then we can inject the onyx and get actually a very nice focal cast of onyx into the AVM proper without any significant reflux in the parent vessel, leading in this case here to, again, complete obliteration of the AVM. And here we have the 3 months control with a nice remodeling and the control on MRI without evidence for ischemia in the calcarine fissure in particular. Here we have another patient who presented with his first ever seizure. Again, we can see some edema, some thrombus in the outpouching here. Here is the thrombus within the outpouching. This is for us kind of like a sign that we should treat earlier rather than later, and we should not perform gamma knife. Given the location in Broca's area, the surgeons were a bit reluctant to treat this, and so we went ahead. You can see that we have a relatively compact nidus. We see the focal venous outpouching here. On the belated phase, there's stasis already within the vein. And here you can see the onyx cast. Again, we are able to do with the septum-mini a very dense onyx cast without refluxing into the parent vessels, leading to a complete obliteration of the AVM here. And here we have the thrombus or the stasis of the venous outpouching. What about transvenous approaches? This will be the last case that I'm showing. Transvenous approaches are also possible with the septum-mini. Here we had a patient who presented with a bleed. As we can see here, there was a small AVM that was fed by the anterior choroidal artery right here, draining here into an infratemporal vein. and the patient went to theater, and the AVM was nearly completely obliterated, but not completely. This is the 3 months control following surgery. And you can see, as compared to before, the vein is still coming a bit earlier than expected. There's a little bit of a blush right here rising from the anterior choroidal artery. Since the patient has bled, we were somewhat wary about gamma knife. The surgeons did not want to go back in again, given the possibility of like scarring tissue. So we decided that we should do a microcatheter exploration. We see here the microcatheter in the anterior choroidal artery. We see the choroidal point right here. So we are here in the ventricle, but the AVM, which is right here, is being fed by this small hippocampal branch coming off the distant anterior choroidal, and we still see that there's a blush towards the basal ganglia here. Therefore, the security margin that we would have in order to embolize this AVM would be literally this fraction of a millimeter here. And therefore, I was not really keen to perform a transarterial embolization. On the other hand, you could see that the vein had a very straight course going here into the transverse sinus. So I decided, rather than doing a transarterial approach here, to do a transvenous approach. Here we can see again nicely the choroid plexus, the AVM, the supply towards the basal ganglia here, 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 and this being the feeding artery towards the AVM, and here the draining vein with a relatively straight course that allows us to navigate with the septum mini first into the ascending portion, and then we were able to make this turn here, having the balloon here, the tip of the microcatheter here, having another septum for control in the ICA, having our Magique 1.2 here in the anterior choroidal artery. And this allowed us then, by inflating both the septum mini and the septum C, to completely obliterate here the AVM from a transvenous approach without significant venous reflux. And as you can see nicely here, with preservation of the anterior choroidal artery. Here are the belated phases, and you can see that all of the branches of the anterior choroidal artery are still patent, and the AVM that was present here was completely obliterated. So again, I have no conflicts of interest regarding this mini balloon, but I do believe that it has significant benefits. Distal navigation is possible. You don't need to have dual catheters for a pressure cooker. The parent vessel sacrifice is really short, shorter than with any other pressure cooker technique, and you have really good control on the liquid embolic agent. And with this, I would like to thank you very much for your attention.
Okay, thank you, Professor Timo Kring, to give us about the new techniques or new device to use for curative AVM embolization. As we know, the AVM is really difficult to treat as curative in the first time, except a small one or just single feeder. But the complex AVM, if we treat it as the target embolization, maybe we need to long-term follow-ups. But now new device have like a heavy small one, and the compliance of the device is really good. So Professor Timo Kring show us about how to use this to adjunct about the curative treatment by onyx embolization. It's very, very good. Maybe we can have the question and send him by email or contact him later by persons if we can see him or meet him in any conference. Okay, we move to the next speaker. From the next speaker, we would invite Professor Ichiro Nakahara to talk about the experience with 100 consecutive cases of cerebral aneurysms treated using the woven endobridge, the technique insight and application in atypical cases. Professor Nakahara, now he is the professor of the Comprehensive Stroke Center in Fukushima Health University, Aichi, Japan. Professor, please give your very special talk. Yes, we can hear your voice.
Okay, I will share my screen. Can you see the slide?
Yes, we can see your slide.
Yeah, okay, so I'm going to start my talk. It's my great pleasure for me to present a paper. Sorry about this. My talk today is regarding the aneurysm treatment using the woven endobridge, abbreviated as WEB. And particularly, I talk about the atypical cases. And this is the slide showing the evolution of the endovascular devices for the cerebral aneurysms. I saw several devices by the previous speaker's presentation, and you see since the 2015 in Japan, so the device has come, and then in 2020, these kinds of a new device has reached us. Currently, several new devices for wide neck bifurcation have been provided. The left column is showing an intracerebral flow disruptor. We have several devices, and still in Japan, we have only a woven endobridge WEB. And so many intracerebral devices have been developed and put into clinical use, including some potential promise. But some have been already discontinued, like this one. And right now, the WEB is only a device with a long history of clinical development, improvement, and evidence since 12 years ago. So I'm using only a woven endobridge like this. This is for the young interventional neurosurgeon and newcomers. So this slide showing the different concept between flow diverter and intracerebral flow disruption. You see that the device is only inside the aneurysm and sealing the neck like this. So metal and endothelialization occur only at the neck. So this device basically does not require the antiplatelet agents and less risk of distal embolization and parenteral artery stenosis compared with the flow diverter. But case selection is much more difficult than the flow diverter, and technically much more difficult than the flow diverter. And this is the schema showing the neck area, comparing coil and WEB. So like this, WEB can seal the neck with the endothelialization by the very high metal coverage ratio at the base of the WEB, like this. Flow diverters metal coverage ratio is about 30 to 40%, but WEB basic metal coverage ratio at the base of the WEB is about 60% in average. And this is the current condition of the distribution. In Japan, we started to use this 3 years ago, and currently the number of the cases is about nearly 500 at the end of January, and the number is recently increasing very rapidly in our country. And this is the location used for the aneurysm, ACOM, MC, and then basal. This is a very typical location, but you can see some other locations like CPC or like that. So I'm talking about this later. Currently in my department, we use a WEB as first device for the wide neck bifurcation aneurysms less than 10 millimeter in diameter. And then we if the web is not applicable, we consider about the complex stenting. Well, of course, direct surgery, clipping, or combined with bypass, like that. And this is a summary of our experiences with 100 cases of web treating the sorry. And among this, about 20% is acute subarachnoid case, subarachnoid hemorrhage cases. I mean, ruptured. Again, the distribution of the location is like this. About 75% is typical lesion, typical location. And this is a very straightforward basilar tip video. You can see the catheter here. I put the micro catheter here, and then just deploy the web. It's very easy, straightforward for these kinds of terminal type aneurysm. It takes less than 1 hour to finish the procedure. Yes, and our result is like this. Implant success is almost 100%. 2%, 2 cases, it was a very small one, so smallest web could not be put into the aneurysm. And of course, we have some complications, but most of all the very mild, and morbidity rate is only at 2%. There are some problems with the sighting. I don't mention about this today, but about 20% size exchange rate ratio is, I think, one of the major problems. And this is a summary of our cases, 100 cases, under follow-up 1 year to 3 years now. And ruptured case is 80%. 18%, and the complete and near occlusion ratio is about 90%. It's just the same as previous large studies in Europe and the United States. And like this, I'm sorry about the morbidity. Morbidity is 1%. This is the wrong. Morbidity rate is 1%. Its mortality is 0% with our experiences. And this is also showing the DSA follow-up. Complete and adequate occlusion ratio is very high, the same as the international study. So the overall results of our 100 cases are very nice. And I'm talking about a little bit about atypical indication for these devices. Atypical indication includes the atypical location and also atypical strategy. Atypical location is, sorry about this, atypical location, such as ACON, Bajirato, MCI symptoms. These are typical, but we can apply this device at some other locations. This is the same thing, but usually where is considered for the wide neck bifurcation, but sometimes we can use this for the non-bifurcation type aneurysm, and also bifurcation and terminal type aneurysm like ACOM, MCA, Bajirato. This is a web on level. But ICPC, distal ACA, Bajirato ACA, BA pica, like that is non-terminal. Even for this, the aneurysm, this is web is on level in Japan. I think in some other countries, these are off level, and also we can apply some web for some off level locations. If the aneurysm specific anatomy of the aneurysm is very suitable for web, and also if the patient is not applicable with antiplatelet agents, it's very nice to use a web. So these are atypical locations. I show you some examples. This was a patient with a very large meningioma on the right side, but the tumor extends to the left side. And the tumor surgeon asked me to occlude this aneurysm buried in the tumor. Here, this one. And this is the angio left paracranial aneurysm, about 6 millimeter to 7 millimeter in diameter. This is also very nicely treated. It can be treated by the flow diverter, but they don't want me to put antiplatelet agent, so I decided to treat this by a wave. So this is a wide neck, but not bifurcation, non-branching site, but like this. Now wave treatment was possible. Unsheathing the delivery catheter and opening the wave device like this. This requires a special technique, but now wave is opened and seal the neck with the base of the wave and then detach. Yes, after the 3 months, the aneurysm was completely occluded, and then a tumor surgeon took the brain tumor. Another case, I see anterior choroidal aneurysm. Here you can see the anterior choroidal artery. This patient was condition before the valve surgery, heart valve surgery, frequent surgery. So they asked me to treat with the treat this one using the endovascular technique. Also, of course, this can be clipped. This you can clip this one, but he was the condition before the heart surgery, so they don't want me to do a craniotomy. You can see some blood here, and this was also did by wave treatment, like this. Put the wave here, and we can preserve the anterior choroidal artery very nicely. Yes, this is the origin of the anterior choroidal artery. And then she underwent heart surgery 1 month after the wave treatment. This is another case, ICPC, and fetal type PCOM aneurysm is very difficult to treat by endovascular surgery. Even if you put the flow diverter here, if you see the fetal PCOM, it's very difficult to close the aneurysm with the flow diverter. For some of these conditions, I think there's a possibility to treat these one with using the wave. So fetal type PCOM ICPC, this is the chart of our strategy. Finally, occasionally we can treat these kind of aneurysm using the wave. And for these very difficult locations, you can see a special technique to put the wave using a special technique, such as this angulation between parent artery and the axis of the aneurysm. This is angulation more than 45 degrees. It becomes very difficult. Also, you can experience some deviation of the axis between these two lines. In these cases, it is very important to use this technique. Yes, you unsheath the catheter at the neck and little by little inflating the wave like this, and finally pushing the wave. So we call this blooming and pushing technique. And also another atypical indication is advanced technique. So this is atypical strategy, such as stent and wave, and flow divert and wave, coil and wave, and dual wave. I show some examples. This is the left MC aneurysm, fairly large, and she took the lung cancer surgery. It was very nicely, sorry about this, it was very nicely exceeded by the pulmonary surgeon, and then they asked me to treat this, and she was very old but very large and anything like this. So I put the wave here and put some coil here and preserved with this anterior temporal artery. So this is there is a measuring, and I selected one type of this wave to seal here like this. And then after that, I put the another coil here to occlude the neck remnant. This wave and coil and preserve the anterior temporal artery. This is final angio. This is another case, 54-year-old female left by the ACNS, initially treated by the coiling by some other place. It looks very nice, but 1 year later, there was some recurrence and they put some coils again. And after that, they followed this by the MR angio, and year by year, you can see the recurrence of the annulus at the base of the dome. And finally, it became asymptomatic, and she comes to me, and when she came, there was a very severe neurological deficit. I wondered if we can treat this, and I think it is very difficult to treat completely, but finally, with deep discussion with my colleague and the patients, we decided to seal this part with cord and then put the web here. So initially we put the coil here, and then seal this plate, this radial dome with using a web. This is the largest one. This is the final. Still waiting the follow-up angio, and I hope that this will close the neck. I mean, the bottom of the annulus and seal the neck, and I hope that this will be completely obliterated. This is the final case. 75-year-old male, ACOM annulus and bilobular, like this, and this looks very difficult to treat with the coil. Of course, even with the web, it looks very difficult. So this is the planning of the treatment. Maybe I'll use large web, but the bottom of the web comes here, not at the neck, and this part is less metal coverage than the base. So maybe I coil and web, and finally I decided to use this this one. So dual web, one web at the top of the annulus and another put at the neck of the annulus. So this is the working angle, AP and lateral, and two webs here and here, and the later one makes me occlude the neck like this, and it looks very nice. So I was very glad to see this figure at the time, but after 2 years follow-ups, the compression of the web into the annulus occurred, and some part inside the web is still opacified by the contrast. You can see some contrast here, so still we see the part of the annulus. So maybe we need to follow this one much more long time. So this is a final part of my presentation. About 20% of the cases we encountered with the atypical indications and locations, and I think it is very important to not do everything using the web, but you can challenge. But if you can, if you challenge more, the complete obliteration rate comes down. So you have to take care. I mean, you have to consider about this. Current trend of the aneurysm treatment in departments like this, the percentage of the direct surgery clipping is coming down like this, and last year, and about 80% of the cases were treated by the endovascular. Of course, still direct surgery and clipping is required, and it's a very important skill, technology, but I think you can treat many aneurysms by endovascular treatment, including woven and bridge. Thank you very much. Thank you.
Thank you very much, Professor Nakahara, to give a very special talk about very last series of the web treatment in cerebral aneurysm. Do you have comments or questions from the panelists?
So Nakata Sensei, so thank you very much for excellent talk. ありがとうございました。Just I want to ask, the ones after web placement, so once it's recurrent, is it again, is it easy to place additional the web?
Depend on the size of the radial lumen. Maybe a web, maybe additional web, maybe additional coil, but some even can be treated with flow diverters. Or you can clip. Even the web is inside. Yes, it's reported. I don't have any experience to clip anything after the web recurrence, but you can clip even with the web. It's very flexible.
Okay, thank you so much. Excellent talk. Congratulations. This is it.
Any question from panelists?
This is it.
Yes, I have 2 questions actually. And first of all, thank you and congratulations on your series on using a web. And this is a new device and I'm very I would like to congratulate on your case series with very good result. And I would like to ask about the first question is how do you choose the size of the web in your clinical in real cases? How do you choose this your size? Any secret tip for it? This is my first.
Okay. Sizing is very important. The providers, I mean, the manufacturer provides you a selection chart. And basically, if the width of the aneurysm is, for example, 7 millimeter, you have to use the width of the web 1 or 2 millimeter larger. So if the width of the aneurysm is 7, you should choose 8 millimeter, or maybe a 9 millimeter width web. In this situation, if you put the web inside the aneurysm, the web is compressed laterally, and then the height will be increased 1 or 2 millimeter. So the height is 7 millimeter. You have to choose the height, maybe 5 millimeter of web. So if you are using 7 by 7, maybe select width 8 and the height 5 or 6. Yes, because the lateral compression of the web is very important to avoid the movement to shift of the aneurysm, wave inside the aneurysm. So 1 or 2 millimeter oversized in width. We call it the lateral compression. This is very important.
I see. And other question is that when in what situation do you need to consider using the balloon assisted or flow diverter combined with web? What are the cases in your experience?
Yeah. Basically, we don't use the flow diverter and web together. Flow diverter is usually only for the rescue treatment if the wave, a part of the wave comes down into the parent artery. But we sometimes use the assisted balloon to support part of the neck, not to wave not to come down when deploying it in the aneurysm. So balloon assist, you can sometimes use the balloon assist, but you should not use the balloon to push in the part of wave after you detached. I mean you deploy the web. Balloon is for positioning, but it's sometimes useful. Yes, so balloon assisted wave is possible, and sometimes you can use it.
Yes.
But you should not use after the balloon.
Yes. because I can imagine the difficulty if you are using the furrow and push technique, and then but you still have another catheter with the flow diverter, so it might be not very easy.
Yeah, sometimes we need to combine web and stent if the part of the web comes out. It's about 10% in our cases.
I see.
Usually we use Atlas, Neuroform Atlas.
Thank you. Really good experience. Really good experience sharing with this. Thank you so much.
Thank you.
Professor, can I ask you one question?
Yes.
Do you have an experience to use the web in the rupture case?
Yes. 20%.
Do you have any problems when the aneurysm obliteration may be delay or postpone after web insertion?
Pardon? Delay? What?
Yeah, because in the rupture case, we concerned about if you cannot like totally occluded about the rupture point. So we still very worry about rebleeding, but I am not sure about the web cannot occlude totally or not because the space or the morphology of web. Thank you.
Okay. I understand your question. If you see the rupture point, I mean the bleb, very near the neck, you should not use a web. But maybe in 80 to 90% bleb rupture point is not near the neck. So web can prevent the relapture. Actually, we don't have any relapture after the placement in the acutely treated ruptured cases. Of course, it's only 20 cases, so I don't know in the future, but usually no rebleeding after the complete web treatment. It is reported in many literatures.
Thank you, Professor. Okay. Thank you again for a very great topic that we receive very much knowledge to use about this device. Yeah. Okay. Maybe we can continue to the next session. For the next topics, I would invite Professor Yasushi Matsumoto to give a talks about the usefulness of Japanese IED coil for endovascular surgery. Professor Yasushi Matsumoto now he is a professor at Department of Development and Discovery Interventional Therapy, Tohoku University Hospital. Please,
good.
Professor.
Can you hear me? And can you my slide? Can you see?
Yes.
Okay.
I can hear you. Yes.
Okay, let's start. Thank you, Mr. Chairman. My name is Yasushi Matsumoto from Tohoku University. It is my pleasure to have
松本先生、スライドが、スライドショーになってないです。
あら、そうですか。はい。
ちょっと
待ってくださいね。スライドが出てないですか？
今出てますけど、スライドショーにしていただいて。
そうですね。ちょっと待ってください。
でかくしてください。
はい。ちょっと待ってください。いかがでしょうか？
今はね、なんか先生の書いたアンチョコも全部見えてて。
そうですか。はい。ですね。ちょっとお待ちくださいね。あれ、どこでやればいいんだろう。これも同じですか？
同じですね、今。
ちょっと待ってくださいね。
You can click the most left button with the play button.
一番左のボタンを押して。
そうですね。
上段の。
ちょっと待ってくださいね。ちょっと待って。ちょっと次のスライド、次の発表でもよろしいですか？すいません。あれ。
先生？
はい。
That he wants to talk after the next presentation.
Can we move to the next? then we can return to him. Okay.
Uh-huh.
Yeah. For the next speaker, I will invite Professor Antri Churajana to give the talk about the embolization of spinal vascular disease. Professor Antri Churajana is one of the my teacher in Thailand. He one of the most founder teacher in interventional neuroradiology in Thailand.
Okay.
He just passed president of Association of Thai Interventional Neuroradiology and the president of Royal College of Radiology and Sira Center of Interventional Radiology. Professor Antri, please give your talk, please.
Okay, thank you, Chairman, for invitation, and also Professor Yakokato for invitation me to be here. So the next 15 minutes, I'm going to talk about embolization of spinal vascular disease performed in our Sira Center of Interventional Radiology. Okay, so just briefly for the anatomy, as you noted, right, that for the spinal vascular supplement to the spinal cord, there are two systems. One is the radiculomedullary artery that supply to be the anterior spinal artery, and also the radiculopyral artery that is in the lateral side and supply the posterior spinal artery. And in the upper cervical level, the posterior spinal artery is similar to the lateral spinal artery. And for anastomosis of the anterospinal and protospinal, there are two systems. The intrinsic anastomosis, you can see that the intrinsic anastomosis that it's in the parenchyma of the spinal cord, that anastomosis between anterospinal and protospinal. And for the superficial anastomosis, that you can see there's that as you know that, right, from the anterospinal is go down until to the basket and then go posterior to anastomosis with the posterior spinal, and also around the cord. That is the vasa corona, that is anastomosis between the branch of anterospinal and protospinal. So to understand this, you can make the things easier. So it's lovely that the disease that I mean, the disease of the spinal cord, vascular disease, that it's it whole that they depend on the space that they belong. Just if it interdural space, it can be spinal cord AVM or primary AVF, and definitely the artery supplied anterospinal and protospinal. But if it occur at the dura, is it the dural, and also then artery supplied the radiculomeningeal, and also with the epidural, there's the outside, and also outside paraspinal, that is the paracaudal or paraspinal AVF. Okay, so lovely. The classification that I think is make it easier. That I lovely differentiate for the malformation into 4 types: intradural spinal cord, spinal dural, spinal epidural, and paracaudal. For intradural AVM or AVF, right? So because it's occur inside the dura, so it's lovely. It can supply. It can differentiate to be fistula type or nidus type. In terms of embolization, I think that the phylum AVF we can include into the fistula type by the mean of the same thinking and same concept of embolization, right? For this, the goal is to complete here because it's not difficult, right? Because it's just only a connection between artery and vein. And because of the anterospinal, and you may see that, and you use the shorted length for that. And almost always that to remember that you have to mark your goal and not allow any embolic material or even retain the microcataract tip inside the anterospinal. And for my experience, I use small size of fluoridated catheter and always use glue. It's a lot of concentrate myself. It's about 25 to 40%. So just like for example, this is 10-year-old boy that came in because of interventional hemorrhage. And you can see that this is the fistula type that is supplied from the anterior spinal, this one, and this is from the left vertebral artery injection. And you can see that you can recognize the same vein that is supplied when you inject from the right supreme metacostal artery. So now you know that the goal, you have to cross this. And I choose this because this is the easiest one, right? Not difficult to go with the microcatheter up to here. And your goal is to close this. And this is immediately after you close this vein by using glue. And from right supreme intercostal artery, you can see that there is significant reduction of the venous outlet, and you can see that anastomosis just also go up into the same anterior spinal artery that you can see here. And on follow-up, that everything is gone. Okay. Another case of the spinal AVF, that is from the anterior spinal, and you have to recognize that from the radiculomedullary artery, it's go and just have the turn out from the axis. Okay, so this is your margin, and then after we put my microcatheter in there, and this is the glue cast, and you can see that the glue cast that it stopped just immediately because of in front of the anterior spinal artery, right? And the post embolization that the fistula is already gone, and you can preserve the anterior spinal axis. In this case, a 19-year-old male came in because of spinal congestion. And you can make diagnosis that is the phylum AVF, right? So the distal most of the anterior spinal artery goes here. So your point is here. So you put the microcatheter down there, and here this is the tip of the microcatheter. And you know that you inject that the glue should not go beyond the microcatheter tip, and this is post-embolization. For a little word about the phylum, right? As you can see here, that you know that because by the anatomy, you know that anterior spinal artery distal to the basket, it doesn't mean a thing, right? When you see here, then you mark that is the spinal the distal of the conus is right here. You draw the line, and even you can see that the shunt is go down there. Now you feel better, right? Because we have just a long safety margin. So just right here, you draw the line, and you just inject here, right? You draw the line that not every nut go beyond that line. And here this is a glue, and even there is some reflux up, but it's still okay. With complete get rid of those shunt. For the nidus type, just like in this case, 11-year-old boy didn't came in because of hemorrhage, but just only the pain, the neck pain. So as I told you before, that we find the shorted loose and the easiest route. Just right here, you can see that you identify this anterior spinal axis, right, from the level above, and here go down, and here at the arrow point, you can see that this is another radiculomedullary, right? Come to here with the same thing, a little bit just level down here, and even from the posterior spinal here. After we saw this, and we think that it's better and to go by the posterior spinal, and we just inject. And remember that I say that we try not to reflux beyond the catheter tip, slowly injection here. And so this is, you can see that immediate result is okay, even, on the 1-year follow-up. And because of number one, the symptom is gone. And number two, you can see that even the nidus is still there, but there is, it can empty out and no any reflux. So we need not to do, because if we do more, probably the patient will get more morbidity for that. Another case right here that came in because of congestion. And when you inject here, Number one, you have to identify that is the region is right here, right? And now you recognize that is radiculomedullary artery, and this is the anterospinal axis, right? So this is anterospinal axis above and go here and go down here and then here. So when you know this, right, your microcatheter should go until away from the anterospinal axis. And then you test injection, and this is how we inject, slowly injecting of glue. Normally in the spinal nidus type like this, we usually use the more diluted glue, roughly at about 25, not more than 30%. And this is the glue cast right here. And you can see that immediate, even though something left, but when we wait about the benefit and complications, so we think we left the patient like this, and she's still okay. Another year-old girl, 2 years, came in because of hemorrhage, and you can see right here. And the AVM is at the corticomedullary junction that supply from the radicular branch from the vertebral artery. So, and we're also with the false aneurysm, intrarenal aneurysm. Definitely, we go and slowly inject the glue, and finally, just only one shot, and we leave the patient like this, because we know if we go more until angiographically healed, the patient may not be that good, right? And she is still okay on follow-up. This is another case that is a long time ago. The patient even had the surgery before, but came in because of a hematomyelin. And you can see that it's a pouch here. And this is definitely small nidus AVM, and with a pouch just close to the anterospinal. And in this case, it definitely to clearly demonstrate the anatomy, even on the lateral view, right? And you know that, right? This is the anterospinal axis, right? You should hook up your microcatheter away from the anterospinal axis. And it's better if you can demonstrate the picture, you can understand more. And we finally success to hook up our distal microcatheter up to here and slowly inject just 1 drop or 2 drops, just enough. And this is what it is. And also you can see that it still have the persistence of the preservation of the anterospinal axis, even though something left, let it be like that. It's not always that we can do, right? Just like in this case, the patient had Park-Weber syndrome, and you can see that in several levels of intramedullary nidus, and also with a significant of congestion. And you can see that it's small supply, right, at too many levels of the spinal cord. So we just that if we do embolization, it will cost risk more than benefit, so we didn't do anything. So I go more with a spinal dural AV shunt. Spinal dural AV shunt usually it's just only one fistula that are between the artery and the vein supplying from the dural artery, right? And usually the history is the more common in aging, in aging, and the patient came in because of the congestion. So the thing is the same. You try to identify, right? To identify where is the shunt is, and you need to do your embolization with the distal artery and the proximal vein now. And particularly if you cannot control and your glue is spillage more into the vein, it's recommended to give the heparinization for a few days to prevent further spinal venous thrombosis. And sometimes, if you cannot do, send the patient for surgery. So like in this case, came in because of congestion, and similar case, right? When you identify the thing like this, and almost always that you have to demonstrate the anterospinal before embolization, right? This, and when then you go with the microcatheter and you test here, and this is a glue injection, and this is the result that it's already gone. And be sure that when you when you embolization, you need to do control from the one above, the one below, and on the other side to make sure before report that everything is gone. And always go back to demonstrate the anterior spinal that is still there. Sometimes it's a little bit difficult because the patient already had the spinal surgery before, and finally you can find the vein there and go there, and similar thing after you do embolization and to go back to control the anterior spinal axis is there. Lateral sacral, it can supply, right? Lateral sacral. If you do all of the vertebral level and you cannot find the shunt, the last one you need to go to the lateral sacral, just like in this case, right? The shunt is right there. This is from the lateral sacral, and you inject the glue in similar things. And just like in this case, right? It's too tiny, so in this case we send for surgery. And also with something like this case, right? The vertebral artery just ending with the pica, and it's also supplied the shunt. In this case, we send for surgery. Spinal epidural shunt, sometimes from the MR, the history, you cannot separate each other from the dural shunt. But it's okay here, just like in this case, right? You can see that the artery supply is also the dural artery, and then it go to into the epidural space, and then just have the vein just running up, okay, like this. So in this case, we prefer, if something like this, we prefer to use the onyx, right? Because your goal is just to occlude this vein just enough, not have to everything just go into the venous channel. And sometimes this case that combine of both dural shunt on the right side and epidural shunt on the left side, and because it's tiny vessel, it's vertebral artery, so this case was sent for surgery with satisfactory. So I'm gonna be finished with something that just like similar, look like spinal, clinical presentation look like the spinal, but actually it is not. It's just like the connection from the intradural, from the cranial and go down until to here. Just like in this case, the shunt is from the posterior spine, from the posterior meningeal here. The shunt is right here, and our staff, you can see that it's they just slowly injected glue at similar to this point, and finally everything is just okay. And the patient is just a good outcome. Similar to this case, this is the last case, right? 22 years old female came in because of the spinal, seemed to be that there's a spinal symptom, but actually you can see that it is supplied from the meningeal artery to the sigmoid sinus, and from the sigmoid sinus here, it refracts into the spinal cord vein. So after we know that, it's not difficult, right? We just occlude this by using glue also into the thrombosed sigmoid sinus, and everything's fine. So finally, I would just say that for the spinal vascular disease, correct diagnosis is very, very important based on understanding and demonstration of spinal vascular anatomy, and that you have to explain the symptom that related with the fistula beforehand. Goal treatment, if you cannot cure, just to reduce symptom of venous congestion and to prevent new hemorrhage, and demonstrate good angiographic picture by 32, and very important, and you have to mark your safety margin of embolization beforehand every time. So if safety margin is too short or impossible, send the patient for surgery. And almost always think that risk-benefit ratio is always consideration rather than angiographic here. Thank you very much. Sorry for a few minutes delay.
Thank you, Professor Anshri, to very excellent talks and very, very beautiful image that we can understand easily for about the really difficult disease. Yeah, that you can summarize to us in many, many points. So, do you have any question from the audience? Dr. Petra. Dr. Petra, can you hear me?
Hi, hey, Pichai.
Yeah, I know you are one of the expert of spinal vascular disease. Do you have some question?
Oh no, I think it's excellent. I think the way to go is for embolization first, like Dr. Anjali has shown us. Only very few cases actually need a surgery. So I think it's a very excellent presentation, and I'm very happy to hear that. Thank you, thank you.
If Professor Anshri, can I ask you one question? For about the techniques of glue embolization in the spinal vascular disease, or do you recommend about the continuous injection technique or the pulsatile injection techniques? Which one do you think is more precision or like effectiveness of the techniques?
Okay, it's hard to say. You know, when you injected glue, you watch at the screen and your reflex will teach you how to inject, right? You know, because the goal, the thing that I always teach is number one, the catheter should not be wet. Should not be wet, because it's going to be reflux into the parenchyma that is more serious. Okay, so the catheter is not wet, and you inject slowly. So it's going to be continuous or stop for a while. It depends that you see this thing on the screen. Just like if you for the nidus type, if you first inject and you see just like it go far away to the vein because of maybe your concentration is too low. Okay, you can stop for a second and you slowly inject again. Okay, something like that. And if it's proper, you continue inject. But the thing is that you have to go slow. So that's it.
Thank you so much. Very clear.
May I say something also?
Okay, please.
Anil Karapurkar here. Sometimes we find that the glue does not go into the vein. It spreads into the other branches, even though we get as close as we can. Sometimes we just cannot get to the foot of the vein. I mean, as close to the vein as possible. Sometimes we are some distance away. So what do you do in such patients? Because sometimes it just does not go to the vein. It goes into all the other branches around. And we have had to send such patients for surgery because they improve for some time and then they deteriorate again.
You know, definitely, you know, if you use glue, right? If you use glue because your time is rather short, and if the first injecting, the glue is not going to the vein and it reflux, I'm gonna stop there. Because if you inject again, it's not like an onyx, right? That when you inject, it's gonna go. And if you inject, it's gonna be more reflux and more serious. So I think it should stop. And we may try to find if there is a supply from the other, particularly in the nidus type, right? Or even if you block to proximal, and you can find the anastomosis just like from the PSA or from the other branch, and you try that. So if you cannot, stop and send for surgery.
I meant mainly for dural levi fistula.
Yeah.
AVM, spinal cord AVM, usually the penetration is much better. It's the dural levi fistula which I sometimes find we are not able to reach the vein.
You know, if dural fistula, you cannot reach the vein, it will never heal.
Exactly.
Right? It never heal. You have to occlude the vein.
Yeah, absolutely. You have to get the foot of the vein. Thank you, Anjali. Very nice lecture. We covered everything in the spinal cord area. Thank you.
Thank you, Professor Anil, for your question. So, do you have another question?
No, that's it. Thank you.
Okay, thank you. Okay, thank you, Professor Anshri, about your topics again. So we just move back to Professor Matsumoto about his talks. Please,
Can you
Professor.
see my slides?
Yeah, sure.
Okay. Okay. I'd like to give special thanks to the president of ACNS Endovascular Neurosurgery and Interventional Neuroradiology, Professor Yoko Kato and Professor Itichai. Today, I'd like to talk about the usefulness of Japanese IED coil for neuroendovascular surgery. This is my COI disclosure information. So IED coil has unique detachment system, and this generator is also able to detect the best detachment point by indicating of sounds and light signals. When the detachment part of IED coil has passed the second marker of the microcatheter, connect the IED clips to the end of the pusher. In this state, a red signal will shine and deep will begin to sound. Advance coil further and confirm that green light will turn on and the sound will stop. This is the appropriate position which ED coil can be detached. Green lamps blinks and buzzer dips intermittently. At the time, press the detach buttons to detach the coil. Green lamp blinks, the buzzer dips intermittently. So, okay. I will show you the video. Can you hear the sound? Sound and light accurately indicate the detachment point. So you don't have to look at the marker of the microcatheter and coil. This detachment is very good system and precise. Okay. So next, I will show you the illustrative case. This unique detachment system with the sound and light is very useful, especially when you embolize such a giant aneurysm. Sorry. Oh, sorry. So my computer is stopped. So wait a minute. Sorry. At the time, I don't have much experience, so I planned pipeline-assisted coil embolization. If it were now, I would treat it just pipeline without using coils. These DA images are taken when the first coil is inserted. You can see the proximal marker in the left image, but not in the right image. After this, many coils will be inserted, but the proximal marker will be even more difficult to see. Can you see the marker? No problem if you use the IED coils. IED coil detachment system can detect the best detachment point by indicating of sound and lights, even when physicians cannot see the second marker of the microcatheter. Post-pipeline assisted coil embolization image, coil embolization result is perfect. And the tip of the ID coil is very flexible. Therefore, it prevents kickback of the microcatheter while deploying the coil in the aneurysm. Kaneka succeeded in developing very soft tip of the delivery wire. I will show you the video. This is a video of 1.5 millimeter aneurysm model with a 1.5 millimeter coil inside it. You can see that the detachment zone is very flexible and the catheter has barely kicked back. This is a really useful feature during embolization. This is ID core lineup. Complex series designed to easily fit into the space, and the complex infinity. This is a new concept core with low shape memory for fitting coils. And the complex silky soft is very, very soft finishing coils. This is a slide of complex silky soft design. 3D and helical hybrid inline space. Silky soft is extremely soft, enough to search open space inside the aneurysm and fill this space. This slide shows the lineup of complex silky soft. And the next, complex infinity. This coil diameter of distal loop is 60% for secondary diameter. And the diameter is diameter of distal loop of it's 2 millimeter diameter. This coil is has low shape memory, very low shape memory coils. This is a lineup of complex infinity. Long coils of any shape are very useful. I will show you the illustrative cases. This case was a 22 years old young man. Left M1 dissecting aneurysm caused by cerebral infarction in the left LSA region. You can see here. This aneurysm has enlarged dilating follow-up. So we decided to embolize this aneurysm to prevent rupture. This is a wide neck aneurysm. We plan to do stent-assisted coil embolization. I will introducing the settings. First, insert the 6 French guiding sheath through the femoral artery. Then put the 6 French intermediate catheter in the 6 French guide sheath. Cerulean DD6 is a good intermediate catheter made in Japan. Then put the headway 21 for LV stent insertion and Phenom 17 for coil insertion. The LV stent was deployed into the left middle cerebral artery, and after Phenom 17 insertion into the aneurysm. You can see how it looks in the reconstructed images. First coil was ED coils, infinite coil, 3 to 5 with a length of 20 centimeter, very long and long coil. And this infinite coil does not have its own shape and therefore spread along the aneurysm wall. Here. Second coil was IDES infinite with a length of 15 centimeter. 20 centimeter. This infinite coils also spread along the aneurysm wall and stent. So as you can see, I was able to insert IED coil silky soft even in place. It was difficult to insert as a coil. Finally, I was able to insert 7 IED coils. As you can see, I was able to embolize this aneurysm very well. And ID coil can pass through the marathon catheter and deflector bull catheter. So now we can use deflector in Japan. Marker band of deflector bull is attached 3 mm behind the tip. It achieves both trackability and ease of coil insertion. ID coil pass through the deflector bull and marathon. I present a case of intracerebral hemorrhage with parietal convexity dural AV fistula. You can see the hemorrhage on CT image. DSA shows left parietal convexity dural AV fistula. Feeders are middle meningeal artery and occipital artery, and drainers are vein of Trorad. Shunting point is near here. This case is diagnosed as corneal type 3 and Boden type 3. A left internal carotid angiogram, AP view, and lateral view shows venous congestion you can see here. Guiding catheter is 6 French Fubuki. Intermediate catheter is 3.2 French Tactics, and deflector ball, and micro guide wire is Chikai X10. And this combination is the best in trackability. And the deflector bull is easily reached near the shunting point. Shunting point is here. The tip is deflector bull is here. And amazingly, deflector bull pass shunting point easily. You can see here, here is the marker, and this is the tip of the deflector bull into the draining system. Deflector bull pass the shunting point, so you can imagine glue injection from here is of course dangerous. So I place 3 ID coils at the foot of vein through the deflector bull. After 3 coil placement, dural arterial venous fistula has gone. For complete obliteration, deflector bull was slightly pulled back and injected with Onyx 18. You can see the complete obliteration of convexity dural AV fistula. Left internal carotid angiogram shows no venous congestion. And the post-operative course was uneventful. So this is a slide of global expansion map about ED coils. ID coil is very good and has gained strong support from Japanese doctors, especially with the introduction of new version of ID coils. The market share is growing rapidly. In conclusions, ID coil is made in Japan and has a unique detachment system that can accurately detect the detachment point by sound and light. Silky soft has large and small coil loops. Large coil loops find open space and small coil loops follow to fill. Complex Infinite is low-shape memory coil and can be first choice for stent-assisted coil embolization. ID coil can pass through the marathon and deflector bull catheter, and I believe this combination is very useful in various situations. Thank you for your attention.
Thank you so much, Professor Matsumoto, for your very interested topics. Because the special coil because for international or another country, maybe we don't have experience to use a Japanese coin. We just use only the current market coin, very common company. Okay, it's very interesting, Professor. Any question from the floor?
Yes, I have a question to Professor, and thank you so much, Professor Yasushi, for attending this lecture and great sharing on the Japanese coil. Seems it's very promising. May I ask in your daily practice? So, do you use this coil from framing to the end? So you only use run band, or you use a mix? Or you prefer you mix blend with some harder coil during the framing of the aneurysms.
Okay,
So
thank you. Okay.
this is my first question. Maybe you can answer this first.
Okay, thank you for your question. So now this depends on the situation. I mean, a simple coiling or a balloon-assisted coiling. In such a case, it's ID coil is actually I believe we have more better framing coil, such as Mechatronics coils, framing coils. But the stent assist coiling, when we will do the stent assist coil embolization. So ID coil is less ID infinite coil, less memory. So for the framing coil, in the case of the stent assisted coiling, in such a case, framing coil is ID infinite coil is a good framing coil. But just simple coiling, it's not so good.
I see. And yes, and another question that I want to ask is that, for example, when you do the stent assisted coiling, so I remember that there are some ID coils with low memory and so many loops.
I'm sorry, I can't hear
those small loops get inside the stent?
I'm sorry.
So sometimes when we do the stent assist, can you hear me now? Yeah.
Yeah, the sound system is not good.
Ben, once again, please.
Once again, please.
Sure. Can you hear me now?
Yes.
Now it's okay.
Yeah. I want to ask, my second question is that when during the stent assisted coiling, I remember that the Japanese coil is quite soft and has no memory with so many loops. So will those small loops sometime easily get inside the stent during the deployment of the coils? Would that be a problem?
No, so never.
Never.
It's okay every time. Of course, you should see the moving of the coils.
I see.
Okay.
Very promising. I can see that is now.
I mean the infinite coil is a low memory, so the less chance to move into the inside of the stent. But the small diameter coils, such as 1.5 millimeter coils, there is a high risk to move into the stent.
I see. I can see that in your slide that is under regulatory process in Hong Kong. So maybe we could possibly use it, see these calls in Hong Kong very soon. Thank you so much.
So in such a to prevent such a case, we will use a longer coil.
I see.
Thank you very much.
Thank you, Dr. Ben, for your question. And how I can ask one question, Professor Matsumoto? How about the thrombogenic effects of the IED coil in Japan? Because if the the homogeneity of the coil is too much is not good, but it's because it can cause the embolic events or complication. But it's very less for homogeneity is not so good also because it's left aneurysm obliteration is really slow on very long times. How about for IED coil in your country?
I'm sorry, I can't understand your question.
Okay. Because the coil have should have like a the homogeneity effects. That means if it's a coil match about the bloodstream and cause of the thrombus, right? Yeah, because the good coil should have this quality to make aneurysm obliteration. But how about your coil is have like this effect also, or comparing about the Striker on Metronics company, it's still same or difference?
Still same. I think same.
Thank you. Professor Anil, do you have question?
No, thank you. No, I don't have any question.
Sorry, can I
But
make
it was a very nice presentation. We haven't used these coils yet. We don't have those coils in India.
So sorry, can I ask just one last question about so I would like to ask in compared to the other coils, so how much percentage is there a difference in the percentage of the volume of the coil inside the aneurysm compared with the other brands? So would that achieve would the IEDC coil could achieve a better a greater volume inside the aneurysm because the softness.
Yeah, exactly. Yes. We can achieve the more high percentage of VR ratio using the silky soft most softest coil of IED.
I see. Usually, how much percent in your case?
So it is actually speaking, it is difficult to calculate the percentage of VR, but about 30 to 35%. It's much higher, I think.
Thank you.
Thank you.
Thank you very much.
Thank you very much, Professor Matsumoto, for your topics. Okay, we will go to the next speaker, Professor Anil Kalapuka will give our talk about the stroke treatment in endovascular treatment. He has a lot experience for neuro intervention. Now he is a very well-known doctor in India, and please, Professor Anil, can you share about your experience to us about the stroke treatment?
Yes, you can click play from start. You can see the button, play from start.
Yeah, but you can see our screen.
Yes, I can see your screen.
Okay.
You can make it to presentation mode and
yeah. Is that all right now?
Yes.
Okay. Thank you very much for having me here, Professor Kato and Professor Tichai, and the ACNS committee. I have enjoyed the presentation so far. I'm going to talk about stroke. It's a global problem, global burden, 6.2 million deaths per year, and 90% of the strokes occur in low and middle income countries. As you can see, the burden is much more in urban than in rural India. So we have about 4,500 strokes in India every day. As you know, India is a large country. Our population is almost 1.4 billion. And we have 3 strokes virtually every minute. And how quickly the patient deteriorates depends on, some patients are more fast deteriorators, some are slower. But on an average, per minute, 1.9 million neurons are lost and 14 billion synapses are lost. So that is the image of, the magnitude of the destruction which a stroke can cause. And these are the various devices which have been, various landmarks in stroke treatment. So 1995, RTA-PVA was approved. 1998, we started doing intraarterial fibrinolysis. Ultrasound was added to speed up the fibrinolysis. Coil retrievers, the first one being the Mercy device. And subsequently, we had the aspiration, the Penumbra device, and then the stent retrievers from 2013 onwards. In India, we also have the TNK, the tenecteplase available to us. So since 2018, we have been using IV tenecteplase, which I also personally think is more effective than alteplase. So let me talk a little about thrombectomy. Thrombectomy was approved, Solitaire was approved for thrombectomy with or without a balloon guide by the US FDA in 2013. And large bore aspiration catheters were approved earlier. So these are some gradings that we talk about. TICI is thrombolysis in cerebral infarction. So in grade 0, there is no flow at all. In grade 1, there is some flow, some penetration, but there is no perfusion as such. In grade 2A, there is penetration and perfusion. And in grade 2B, there is better penetration and better perfusion, but still not full. In grade 3, there is complete perfusion and complete penetration. So we, as far as possible, try and get 2B or 3 as our end result after we try thrombectomy. Until 2014, there were a whole lot of trials which are all negative, and there was a very pessimistic outlook towards stroke. After 2015, there were all these 5 trials, MR Clean, Extend IA, Escape, Swift Prime, and Revascat, all of which showed excellent outcomes after thrombectomy. And the difference between the earlier one and the new one is that in addition to the CT or only plain MRI, CTA was added, or MRA. So we started imaging large vessels to look for large vessel occlusion. So this is just a video to show how it is done. I'm sure most of you know this, but just for the beginners. So we bring a catheter, big catheter on a small catheter, keep it at the proximal end of the thrombus. Then we remove the small catheter and connect it to a pump. And then we aspirate. And we hope that the clot will get sucked out. Often in the first pass itself, the catheter sucks the clot out. And we have a whole lot of catheters available to us, the Sophia, the React, the Cat6, and the ACE. These are the systems, catheter systems which are available to us. And we have the other device, which is the stent retriever. We personally like the Solitaire. We personally use the 630 or the 640 as far as possible. And we always use it with a balloon catheter, balloon guide catheter. So we cross with a wire, we deploy the stent, we wait for about 30 seconds to 1 minute. We do not do an angiogram because I feel that if you do an angiogram after we have deployed the stent, we may cause fragmentation of that clot and distal embolization and embolization into new territory. So after we have deployed the stent, we just wait for a minute or two and then pull the whole thing back with the balloon inflated so that we know that, so we inflate the balloon and then we pull the whole device back. And again, initially there was only catch, but now we have more and more of these devices. So these are the techniques. It's called the adapt technique, that is the aspiration as the first pass stent retriever I showed you just now. So sometimes the single stent is enough, sometimes you need two stents, sometimes you place one stent in one AC or one P1 and the other in the other P1 at the basilar top. And sometimes both aspiration and stent fail. In that case, we use the Solumbra technique, where we use both aspiration and stent simultaneously and pull both out together. So this is a case where this gentleman had surgery, bypass done, and in the hospital itself he developed a left hemiplegia. And as you can see in the second image, there is no ICA on the right side. The M1 is not seen. This is a very nice picture showing them very clearly. And when we did the DSA, we again found that there was a clot sitting in the supraclinoid ICA, and we crossed with a microcatheter. We do a shoot, make sure that we have not made a hole in the artery, that we are in the true lumen. We deploy the solitaire, we pull the solitaire out, and we have opened the artery. In literally 10 minutes, the artery is open, and we got a TK3 recanalization. And the patient, of course, recovers very rapidly. As is common practice, we do a CT immediate post-procedure. That's the thrombus. Now, part of the thrombus is in the stent, but we often, when we aspirate, when we are removing the stent, we always aspirate, disconnect the suction and aspirate. And we find that there are big clots in the aspirate, in the syringe and in the catheter. And of course, the patient makes a dramatic recovery. So if we are in time, we get a very good recovery of the patient. Within 48 hours, the patient had recovered completely. No, initially we were only treating clot, infarcts which was smaller than 50 ml. It was thought that if we treated larger clots or larger strokes, or if we were late, then there was a risk of hemorrhage. So this diffuse trial and Dawn, these were two trials which were conducted. The diffuse trial was for up to 16 hours, and they found that there was a benefit in 45% with absolute benefit in 28%. And in the Dawn trial, there were 206 patients and the window had been extended to 24 hours. The volume was still less than 50 ml and the stroke NIHS score was more than 20. These patients also showed us a great benefit with thrombectomy. And there was no increase in the symptomatic ICH. So after the diffuse and Dawn trial, we have extended the window to 24 hours. Of course, for all of these, it is important to do imaging. So MRI, diffusion, and perfusion are important. So that you can image the brain which is viable, the penumbra. What we see well is the penumbra. So because we have extended, we now thought about going for larger stroke, larger volume, larger volumes also, more than 50 ml. So there are these five trials which have been done on large volume, more than 50 ml core, sometimes even more than 100 ml core. And even here, the results are very good. The incidence of hemorrhage is only slightly higher. This is another group of studies about one of course, two of these are from Japan, the Respect and the Yoshimura. And all of these have shown that there is a significant improvement over the best medical management. So there is no question that today we should do these patients even if they have large infarcts and even if they are out of the window. So this is one such patient. She had this. She had a complete left hemiplegia, and the CT had ruled out a hemorrhage. When we did the MR, there was a large infarct. The M1 MCA is not seen. We have, as usual, done solitaire thrombectomy, and on the first pass itself, the artery has opened. The patient has done very well. And if you look at that, this is a like a what would you say, a stone, you know. This was to palpate hard. So almost like a plaque which had broken off probably from the valve of the heart and gone into the artery and blocked it. So this came out with and this is the patient clinically. She had a large infarct, so we had to do a decompression. But despite that, she made a very good recovery and she's walking around and doing everything. So even with large infarcts, patients do very well. It was thought that posterior circulation strokes don't do well. Almost all the studies that have been done have been on the anterior circulation. But these 4 studies have been on the posterior circulation, and 2 of these are from China. And again, in the posterior circulation, the outcomes are much better than one would have thought. So here is a patient, 45-year-old, chronic kidney disease, admitted with giddiness. When he came, he had no deficit. So we said we'll wait for a few hours. So as you can see on the MR also, there was a small infarct in the right cerebellum, but we are not seeing the basilar or the vertebral artery. But 4 hours later, he worsened. He became unconscious. He showed brainstem signs, absent time movements, quadriplegia. So we did a CT. We didn't want to waste time now. So we did a CT to rule out hemorrhage, and we took him up immediately. And as we can see here, the vertebral artery is very slow and ends at the pica. Beyond the pica, there is no flow. And as usual, we managed to get a stent in there. And again, we recanalized in the first pass. And on follow-up, he had these small infarcts, 1 in the cerebellum, 2 in the thalami. But clinically, he did very well. And a year later, he underwent kidney transplant. Often patients have stenosis underlying the stroke. So it starts as a thrombus forming at the stenotic segment and the thrombus extending upwards into the. So what do you do in these patients? So this is one such patient. He had an acute onset weakness 2 hours before he came to us. MRI showed a small infarct, and the ICA is not seen right from the origin upwards. So when we do an angiogram, we find that there is a very tight stenosis at the origin of the ICA. So we do an angioplasty with a 3 mm balloon to be able to access. Once we have done an angioplasty, we take the 8F or balloon catheter up. We always do this with a balloon catheter, like I told you. So we take the balloon catheter across the stenosis into the ICA. Then we do the same thing. We aspirate. We use the stent rather, and as you can see, we got a recanalization in the first pass. Now here, because we had done an angioplasty, we were not very keen to do the stenting right away. We said we'll wait for 10 minutes. When we waited for 10 minutes, we found that there was a progressive slowing of flow. So because this was despite doing the plasty and keeping the balloon inflated for almost 1.5 minutes, hoping that the artery would stay open, but it did not. So then, because we had no choice, we deployed a stent here. Now, this patient had already received RTPA. So the debate was whether we should give GP2B3A inhibitors or not. So after much looking up the literature and all that, finally we decided to give half the dose. So we gave half the dose of integralin, 5 ml of integralin, and sorry, an infusion for a few hours, and the patient did very well. As far as possible, we tried not to use a stent in the acute phase because we are not sure whether the patient will end up with a hemorrhage, and we have to give double antiplatelet, so whether we'll be able to continue with them in case there is a hemorrhage or in case the patient needs a decompression. So as far as possible, we avoid. And certainly for intracranial stenosis, we try and avoid. But so this was the patient. He did very well, as you can see here. He had a small infarct here. The artery is completely normal. The artery is completely normal, and that's the stent there. So these patients do very well. So recently, just 2 days ago, we try and not do the stenting for intracranial stenosis, but recently for a basilar artery, we were forced to do it. We did. Unfortunately, I don't have the images with me, but this patient had come with a large infarct in the pons, in the medulla, in the cerebellum, and a total occlusion of the basilar. There was a very tight stenosis of the basilar artery. We were able to deploy cross the stenosis with a wire. Usually we use a tractor. We deployed the solitaire. We did the thrombectomy, and then we found that there was a very tight stenosis of the basilar. So we first dilated with a 1.5 mm balloon, then with a 2.5 mm balloon. We again kept the balloon inflated for about 2 minutes, but the artery would close down again. So finally, we deployed a balloon-mounted coronary stent, and luckily the patient has not had any hemorrhage or not had any complication. So as far as possible, when we are in this patient also, yes, or in this patient also, we had used the GP2B3A inhibitors in half the dose. So as far as possible, we don't do stenting in the acute phase. But if one has no choice, then one has to do it. Artificial intelligence is something which is making big inroads into our practice. And it has 3 components. The computer solves tasks that mimic the human behavior. There is machine learning and there's deep learning. And there are various platforms which are available. The first 3, iDoc, Avisma, and Brainomics, are for hemorrhagic stroke, and Rapid and Viz are for ischemic stroke. I'll just show you an example of how useful it is. For instance, in this patient who had come with a right-sided weakness, laryngo speech, and 90 minutes from the stroke, the NIHS was 12. He had atrial fibrillation as his risk factor. On the diffusion, it appeared as if there was no infarct at all. But when the perfusion scan was done, it was found that there was a small area which was very definitely seen. So on the AI, the rapid software that we have, this was estimated at 31 ml. Actually, this case was given to me by one of my colleagues, Dr. Manish, from another hospital in Mumbai. And when the angiogram was done, this artery was occluded. A thrombectomy was done, and the artery was recanalized. And this patient improved right on the table. And on follow-up scan, one can see the area of hypoperfusion, which has completely gone on the. So it is important, and we do use AI if required. Do elderly benefit? According to the original guidelines, only patients between 18 and 80 could be treated. But we have treated many patients over the age of 80, and 30% had good functional outcome. Symptomatic hemorrhage is slightly higher. Mortality is also a little bit higher, but it is almost the same as that for best medical management. So since patients do well, if they have been active before the stroke, they should not be denied treatment. Similarly, children, Sometimes there are children who have rheumatic heart disease who come with acute stroke. Rheumatic heart disease is still prevalent in India. We do have a number of cases of rheumatic heart disease, and sometimes they come with a stroke. Why deny them treatment? And we have done some children, and they have done very well following the thrombectomy. What anesthesia do you use? Usually we start with local anesthesia. And if it is a dominant hemisphere or a posterior circulation stroke where the patient is not cooperating at all, patient is very restless, then we switch to GA. What is important is to prevent hypotension when giving anesthesia. So GA can be used in Europe. I know most patients are done under full anesthesia, but care should be taken to prevent hypotension during the induction. What is new in imaging? There are various things which are new. Diffusion flare mismatch is now fairly confident. One can say that it is more than 4 hours old, the infarct. Definition of infarct core volume it can be better on this, especially with this artificial intelligence. The collateral system on the CT angio or single phase, multi-phase is better. You can evaluate the cross flow and what is the chance of the patient doing well after thrombectomy. We didn't have a aspect score for posterior fossa, but now there is a new aspect score for posterior fossa. Plaque imaging, if the plaque is vulnerable, and if we find that on plaque imaging, the patient is throwing TIAs, the stenosis may not be much, but if the plaque is vulnerable, we have done stenting. SWI imaging again, and this is a new, which is not yet much used for clinical practice, diffusion proptosis imaging, where very soon I'm sure it will be in, and AI in stroke imaging we have already talked about. What is the future of these? We should have more and more stroke ready hospitals. AI should be available everywhere for we can start neuroprotectives at the site of the stroke if we know what kind of a stroke it is, for which a CT equipped ambulance is very useful, a mobile CT. And large aspiration catheters, now they are talking, the biggest catheter as of now is 72, the React. But now they are talking about catheters which are 88 and 92 mm also. Of course, they come with a caveat. If the catheter is 92, it will probably close that M1 completely. And when trying to aspirate, we may even aspirate or pull out the intima. So we should be careful when we use large bore catheter like the 088 or the 092. Better articulated stent retrievers with drug coating are being devised. The DAISY thrombectomy device, this is the thrombectomy device. These are still under trial. They are still not approved for clinical use. Local cooling by intravenous fluids or neuroprotectors. And this large balloon guide catheter, which can be taken up to the Peters ICA, is now available for clinical use. So even in India, we have this available to us, and we have been using this walrus. In conclusion, today thrombectomy is safe. Stent retriever or aspiration or both can be used to recanalize. Our personal choice is a stent retriever. We start with the guide catheter with aspiration catheter. If the thrombus starts from the ICA, then we can take the guide catheter all the way up into thrombus and aspirate it directly. But if it is in beyond the ICA, say in the Peters ICA or in the M1 or basilar, then our choice is a stent. If after 3 passes the artery is still not open, then we do the Solomra technique, where we use both the aspiration as well as the stent. All this time we have been saying time is important. Of course, time is important, but I think tissue now is more important. And luckily, with the newer imaging techniques, we can analyze the tissue better. Volume of 50 ml was used to be a contraindication, but not anymore. Delay of 12 hours again, and we have gone even up to 36 hours in posterior circulation strokes. These are not a contraindication. age 18 to 80 is no contraindication. And stenting in the acute stage should be avoided as far as possible. But if you have no choice, then we have to use it. And we may need to give GP2B3 inhibitor to keep the stent patent. Artificial intelligence may show salvageable brain when the DWI shows no infarct. And neuroprotection may play a role in the future. Thank you very much for your. This is my team at the Rich Candy Hospital where I work. Thank you very much for your attention.
Thank you, Professor Anil, for showing us about your principal knowledge and about your experience of stroke treatment. Any question from the audience?
Can I? So it says it. Please come.
Please.
Hi, Professor Kalpiko. So long time no see. Thank you very much for excellent talk. So I think India is one of the top leading country, even the endovascular treatment, because of your leadership. So I think usually in India, how fast the patient reach the hospital, the average?
In a rural setting, we don't get patients. In an urban setting, for instance, I live in Mumbai, where the roads are always crowded. There's so much traffic. Unfortunately, no hospital in India has the helicopter service. So if the patient is close to the hospital, then sometimes we get patients within the first 1 or 2 hours. Most of our patients come by about 4 hours. So it depends on how close the patient is to a stroke-ready hospital. But most of our patients that we have treated have reached the hospital in about 4 to 6 hours. The basilar stent for a basilar artery that we did, for instance, I was telling you just now, he reached the hospital almost 10 hours after the onset of stroke because they didn't realize that it was a stroke. They thought it is just giddiness. Until we became actually offended, he was not sent. So diagnosis, especially in posterior fossa strokes, is also a major issue of why there is a delay.
So maybe I think it's another issue. Maybe you should start on site. That is very, very important, which you conclude in this last slide. Thank you very much. Congratulations for your long-lasting teaching us. Thank you so much.
Thank you. Thank you so much.
Professor Neil, can I ask you one question?
Sure.
How about the reimbursement price in India about the device for stroke treatment? The patient can pay for themselves or the government can reimburse some costs for them. Thank you.
Our Prime Minister has started a new program for help, and in different we have many states. In different states, the amount is different, but on an average, the cost of acute treatment for stroke, especially IV thrombolysis, is covered 100%. But for our devices also, I think today in most cities, it is being covered by the state, by the government. At least the acute part. The ICU part, if the patient spends a lot of time in the ICU, then it becomes difficult because then the patient has to pay himself. But for the device, they have a ceiling, they have a limit, and the limit is in Indian rupees, it is 5 lakh rupees, 500,000 rupees. So in that 500,000, we can do the thrombectomy completely, and maybe a day or two in the ICU. Until 5 years ago, it was very difficult. Now it is much, much better. Payment-wise, much better.
Thank you. Any question from the floor? If we do no more question, we will finish this talk. Thank you so much again, Professor Anil, about your valuable talk. Thank you.
So maybe for the next talk is by Professor E.T. Chai. So maybe I will take the chance to introduce Professor E.T. Chai, one of my good friend. And Professor E.T. Chai is the president of the ACNS and Vascular Neurosurgery and Interventional Neuroradiology seminar 2024. This webinar. And he is actually the assistant professor of the Department of Neurosurgery in the Brain and Cerebrovascular Center, King Tassin Memorial Hospital in Bangkok, in Thailand. Today, he will talk about the challenge of mechanical thrombectomy treatment. Please, E.T.
Thank you, Dr. Ben, for your very great introduction to me. And I just have like a small talk. It's not too much because this is just only my experience, but I think some point or some challenge in techniques of stroke, patient treated by endovascular can have a benefit for some beginner or interventional neuroradiologists, doctors. As you know, stroke is not only simple conditions. If we face up the stroke, ischemic stroke, especially large vessel occlusion, in some of them have like a complex disease. That means the patient can have some intracranial atherosclerotic disease or dual pathology or tandem lesion or uncommon stroke etiology like a vasculitis or infection. This is the most difficult case, but we don't know this all of case will come or not. Sometimes we can win about the stroke treatment or the successful, but in many times we fail or feel like a loss about the treatment. So in some situation of the operator should like respect about the whole or lack or in some feeling. I think all of us know very well during performing about the stroke treatment, because the successful of treatment is not meaning only the successful revascularization by the image, but in some cases we can do it very completely revascularization, but the functional outcome is not good. That means it's a functional, not success. So which one we can shoot? It's not very pretty image, but the patient can walk back home, or we can complete together. But I think if we can do it both together, it's very good. But in the real situation, it's not like we can see about two conditions together like this. So the challenge of stroke treatment is depend on two factors. The first one is the patient-related factors. This means this is the major obstacle for treatment of stroke, because in some cases has a vascular anatomy tortuous, or it has like a atypical stroke, or the density of thrombus is very hard, and the patient has the comorbidity of underlying disease, like a heart disease, heart surgery, something like that. But in some factors we should concern, because the operator is also can determine the success or not success for mechanical thrombectomy, because the selective criteria is not complete, good or not good. The techniques, experience, or device that we have in our hospital or our centers. Thus, I introduce you at the first time, we can have a luck or we can have hope. We don't know. Because the failure to recanalization of stroke thrombectomy, we found that about 75%. But in some cases, we go through the cases, but we don't know this is a surprise or just in expectation during perform thrombectomy, because in some cases we see the widening of the aortic arch. That means the access of the treatment is not too easy. In some cases, we can see the calcification on the P-thrombectomy imaging. That means the patient has atherosclerotic disease in the access vessel or intracranial vessel. And the etiology of stroke, in some time we don't know. In some cases, we have atrial fibrillation. We just smile because the clot maybe it's not too hard. It's very easy to retrieval. In some cases, have the many underlying disease like a heavy smoking and recurrent TAA or family history of stroke. In some time, have what treatment about the heart replacement from the CVT or EVA stent. This is the most big obstacle for treat the stroke. And the finals, the expectation of the outcome is depend on the setup of the vessel, the location of the occlusion. Yeah, in some cases we expect to receive the full canalization. In some cases, we just only partial recanalization in major part of the brain to recovery about the blood supply because the limitation of the vessel. For anatomical limitation, as you know, unfavorable super aortic access, like a bovine arch, or the arch type is different, and unfavorable anatomy of the cervical carotid artery. This is have like a really big challenge for the operators. And also, if we can get or in about the access of the femoral artery, radial artery, and aortic arch, we still face of the obstruction or obstacle of the carotid siphons. If they have like the type 4 or type 3, this is maybe difficult to use aspiration catheter as the first techniques because it cannot going off by themselves. Needs to assisted device to carry this device off to the brain or the direction of the stent retrieval from the clot. If we have a two acute angle right like this, in some time the efficacy of the stent to retrieve the clot is not very good because in some cause or some force have lost and cause of the distal embolism. So the planning is very important. So that we should learn and should plan the treatment, start from the device preparation. We should have the many device or necessary device for the stroke, like a balloon, stenting, intracranial or carotid stenting, or medications. Or the side of the vascular sheath, long vascular sheath, femoral or triangular approach. This is specific for that patient. Or the method of treatment, we should aspiration first, or we should combine, or we should stent retrieval. This is depend on the experience of the operators. Like in this case, this is a male, 52 years old. He developed about the unconsciousness and have like a quadric paralysis and a multiple cranial nerve palsy. The CTA you can see about the basilar occlusion along here, but they have like the orifice of the right VA, that is the dominant side, is gone. We cannot see about the origin of the VA. This means in this patient have a tandem lesion for the occlusion in the basilar trunk and the occlusion in the right vertebral artery origin. In the left side is really small, so we should try only one root approach. This is a very concerning point, how we can win about this patient. At that time, I used the common approach by femoral approach. and I cannot see about the origin of the vertebral artery during performing angiography. And I try to use the guide wire. How about to penetrate or to find out about the origin of the vertebral artery? And at that time, I go to the left side instead, but the left side is very hopeless to do mechanical thrombectomy. Is very, very small one, and it's not cannot achieve the catheter upside to the basilar artery. So I try again to use like the micro catheter and micro wire. Maybe I see some knob around here. I think this is one is the origin of the right vertebral artery, but the curve and the catheter I changed many times is cannot go there. For another option, I access to the radial artery because I think that this point can turn off and like can penetrate above the occluded point and follow the catheter. But finally, the radial approach can lead to the occlusion, but the catheter cannot go up, and the guide wire cannot go up. I just thinking, reconsidering again, maybe I can miss some concept of treatment, but I changed another the same approach by use the transfemoral approach again, and I just changed about the catheter. Like the burn catheter is really very hard, and like the angle can reach to the occluded point that I penetrate about the 38 Y to up to the right VA. And after that, I exchange to use the like a aspirate catheter different to go up. Sorry, this is chaperone guiding catheter from my convention. After that, I use a Sophia 5 friend, go up to about the occluded point at the basilar tip. At the time, I think the orifice of the VA also auto angioplasty by the catheter already. And I can use the simple techniques of the aspiration only one attempt, and I can open the vessel. And the origin of the VA is still like stenosis, but there was no delay contrast feeling, so I just wait and see, and the patient is really good recovery. And the cases, this is an 86-year-old male. He developed about the left hemiparesis, and NIS score is 14, and we can see about the right M1 occlusion. But about the aortic arch is not too easy, right? Because the arch have like a arch type 3 like this, and we should think about how we can get the catheter up. It's not too easy. And this is arch type 3. I just this is the Simon catheter. Maybe it's really difficult to up the guide wire upside, but I have tried. But the finally it's just use like a bit long time to just climb up of the catheter, follow about the guide wire. But it's overly most unstable about the aortic arch, about the acute turn curve of the aortic arch type T. Okay, you can perform about the angiography and nose to know they have like occlusion at the right M1, but it's difficult to pass about the long vascular sheet or very hot of the guiding catheter. I think the system is not is not stable because I don't have the stiff Y. So I just choose another approach to the lateral approach. So I think maybe it's to be more effective or not. I don't know, but I want to try, and I just go to about the occlusion point. But I can try to select up to the right ICA and follow with the Sophia frequent up without long vascular sheet, because the radial artery in this patient is very small and it's very tortuous. At the time, I use just place the Sophia around here and put the stent retrieval and do the combined techniques, aspiration and stent retrieval together. And then finally, we can have a successful to revascular right about the right MCA, and the patient recovery very well. This one I just want to puncture site like this in the same patient. This is a very old patient. It's 92 years male. He developed like hemiplegia, slow response, but at initial times, the NISS score is not too high, just only 10. And the CT scan, the brain there was shown no large infarction, just only brain atrophy. But patient very too old. I have discussed with his relative. He just told me only the previous status is he very strong, so he can walk around 2 or 3 kilometers by without any assist device. Please help him. I just very old, but it's very make me very serious. But in this patient have like the region of the carotid artery, it just very have severe calcification and have like a stenosis. And I just try pass about the catheter to the occluded or the stenotic point by the aspirating catheter, aspiration catheter with the guide wire. And at that time, I have the aspirate via through the catheter aspiration catheter and just get some clot. But the some clot has like a distal embolism to the left M1. So at that time, my surgery had changed. I need to retrieve the clot in the M1 first. Then I just reconsidering to manage about the left cervical ICNS scan. At that time, I used the stent retrieval. And for the finally, after I use the stent retrieval, they have okay, it's just like a recanalization, but in some part of the M2 still occluding. So, but at that time, I cannot like to get the clot from the another branch of the M2. I just back to treat about the cervical ICA first. I use the balloon above the angiopathy first because the guiding catheter cannot pass for the second time. And I decided to because the balloon I do it many times, but the lumen of the cervical artery cannot open more, just like a remain severe stenosis. And I think we should do a primary stenting at the time. And after primary stenting, it's still narrowing. I just put stent angioplasty, balloon angioplasty again. And finally, the lumen is very patent and blood is very good to supply it to the intracranial. And I try to use the stent retrieval to about get the clot from to another trunk, another branch of the MCA that have a residual occlusion. And finally, I think, okay, I can fully recanalization of the whole blood vessel, and do also I successful to perform the primary stenting angiography and collect everything, and we can get 100% revascularization. At the time, I'm really happy. But the patient is not happy with me because he cannot deteriorate to comatose condition. I just follow, and the CT scan you see is very like bleeding, massive bleeding, because of have liver perfusions, and we have like antiplatelet by 2B3A glycoprotein inhibitor at that time, and the patient just passed away at the finally. And this is for another case, 64 years old male. He has a history of heavy smoking and hypertension, DM poor control, and he developed an ACNS score at that time 26. We can see the left M1 occlusion. Okay, at that time I use combined techniques, use stent and thromboaspiration. And after mechanical thrombectomy, I think it's very good to revascularization at the M1, but I think there's still like a small clot around here, maybe some chronic stenosis or not. I don't know at that time. Because in his history of heavy smoking, I just wait for 10 minutes. It's a delay contrast feeling. What's happened? I think it's not regular. Maybe complete occlusion in the future. I just wait again until 20 minutes and have a test about the contrainjection. This is expectation, very slow. What about your opinion to treat in this patient? Just primary stenting, because we believe about the ICAT, because the history and about the collateral and some kind of blood vessel, or do redo about the thrombectomy using the stent or end joint. At the time, I scared about to do some primary stenting or balloon angioplasty at the M1. But it's up to you, because if you believe what is the real mechanism of reocclusion in this patient, vasospasm, you need to give some nimodipine. Or if you think about the reocclusion by atherosclerotic disease, you should use the stent, balloon, or some medication like 2B3A glycoprotein inhibitor, or you think the stent caused the vessel injury. This is just only pay and hope. But at the time, I think I don't experience too much to use about the stenting or balloon angioplasty in the M1. I just try to select the micrometer to cross the occluded point again, and just I give the bolus dose of the 2BTA inhibitor via the microcatheter. And finally, the vessel can open again, and the patient really clinical is very good. He's at full recovery, but the CT scan at 24 hours have some bleeding of the brain, but without any neurological deficit. And there's the CTA after 48 hours. I just want to make sure it's still good or not, it's still patent. But in this case, I give about 12 hours of intravenous infusion of a 2B3 glycoprotein inhibitor after switch to DAF. This is TA. It's very, very good about the vessel patency. This is a 48-year-old she developed about left side weakness, and I score is 12. And you can see about sorry, this can work. Okay, it's work. Yeah, it's about right MC dense cosine, and the CT angio show about the terminal or proximal M1 occlusion. And at the time I used about the thromboaspiration techniques. Only one attempt. Okay, we can open the vessel. But for 10 minutes later, you can see the very narrowing at the right M1 that we used about the aspiration catheter around there. Just wait for 10 minutes. This is a progression of the synoptic point and delay about the blood supply to the distal territory. Dissection, spasm, or the blood clot formation. At the time, I should give heparin, BTA, or nimodipine. Because of, I believe that in this case, I use 5 French Sophia catheter, but to compare about the diameter of the normal vessel of the MCA is like quite very small. So the straight law about the force divide with the cross section of area. If we use too smaller catheter, so it can suck about the wall of the vessel together to the tip of the catheter, so it can make like a injury or spasm. At the time, I give some nimodipine and until wait until it's improve about the recanalization, but they have some residual branch of occlusion. I just use like the 3 millimeter of stent retrieval to recanalize another trunk, another branch of the MCA. So in this case, I can open the vessel for TC3 and the patient is recovery well. For my conclusion, the stroke is not simple disease. It's that's true. In some cases of the patient, more than 40 or 50%, it's very easy to treat or easy to access or very quick or very short time from groin to recanalization. But in some cases, it's not too easy, like that I told before. So the treatment planning can achieve the success goal is very important. If we stand alone in the center, so we need to like get more confidence and get more experience. And please tell your in every time you should do no harm. We just do successful or just only to save the patient first. And the unfavorable anatomical factors, some is the major obstacle during endovascular treatment. So if we know about the factors that have some like a cause, the limitation or cause obstacle of the procedure, we should prepare or the correct immediately. So the final, if we continuously improve the skill and update about the knowledge of treatment, this is a promise to improve the treatment outcome. Thank you so much. Do you any question from my talks?
Thank you very much for your excellent talk. And so you experience a lot, I think, day by day. So I think in the world, especially the developing countries, so how we can teach them because they need to overcome so many steps, I think. So, of course, that you learned a lot from the beginning. So, what is the idea? Do you have any idea, or if you have?
For about my idea for the beginner of the stroke endovascular treatment concept, we should know about the basic anatomy and learning about the preoperative imaging. This is an important clue to read us how to do like properly do the best or do as safely for the patient. But in some case, for some exceptional case that I have presentation, in some kind of this case, maybe we cannot do by myself. We need a bigger teams. A second operator, the third operator or the consultant at the time. If we have a discuss together during we perform the operation, I think this is the very most important to reach the patient has a good outcome and the successful of the procedure, Professor.
Oh, I think in our institute we have some system of TASCAL, so the teamwork. So once patient arrive in time, sometimes in between the CT and MRI, it will take a longer time sometimes. So I think maybe they need some leader and some education among the team. I think it's very, very important. I think. Thank you very much. Congratulations.
Thank you, Professor Kato, for your comments. It's very, very valuable comments.
Hello, Professor E.T. Chai.
Yes.
Question. I noticed that there's a case in your presentation with the tandem lesion.
Yes.
Occlusion of the vertebratory region and with the occlusion of the basilartery occlusion. And you have do a lot of work on the recanalization of the region of the vertebratory. So when you do this surgeries, what kind of microwire do you choose? Because I have faced many of these problems. Yeah.
In this case, I don't concern too much about the brand or the type of a microguide wire or the 0.014. Yeah, if because the strength of the anatomy of from the origin of the vertebral artery until the occlusion point of basilar artery is very straight. So I just use only tungsten or Synco microwire. Okay. Yeah, and just follow about the microcatheters. But in some kind of very tortuosity, guide wire, guide wire is not like the most important, but I think the most important is a supporter. Supporter that means about the long vascular sheath or the guiding catheter. This is the most important because if they have like a limitation of the widen of aortic arch or tortuous of the carotid artery or vertebral artery, I think that the support by guiding catheter is really the most important. Can support about the microguide wire can follow with the microguide wire to the occlusion point. I think this is my principal theory.
Yes, I agree. Sometimes I use the 8 French guiding catheter and sometimes I will shape the tape of the guiding catheter to the direction of the vertebratory. Yeah,
because it's very hard about the 8 French. This is my in my center also we use in every case, but exceptional case like in like this case is the patient has a very small caliber of the origin of the parent artery. That's I change to 6 French of the guiding catheter, and I try to use a smaller like a aspiration catheter in 5 friends to go up, because I think I have only one chance to treat the patient. If I lost about the direction, so maybe spontaneous occlusion and I cannot go up again. So
Yes.
this is a meaning everything fail. This is I just like constantly in many times.
Yeah, thank you.
Maybe my teacher can comment.
Yeah, I just want to make one comment. At first, I want to appreciate and would like to say that you're doing very great job. To let all of you know that one of our limitation in Thailand, right? Apart from the medical school and the big hospital, economic is one of the concern things, and reimbursement system and everything. And so I appreciate, that as Itichai say that the first thing you have to think, and you just not strict to that the material. If we use this material when we learn, so we have to use this one. I mean that the application is very important, right? You should have the idea of application to use any kinds of material instead. And number 2, this is very important, as the Professor Yoko say, that about the teamwork. And you need strong heart, strong mind, and to do everything. Okay, so appreciate what the thing that you have done. And the last thing is that you make, how to say, decision to stop may be important also. I know sometimes it is very hard, right? Because just like when we just on the tiger back, we mean that we need to pursue and we need to win, but actually sometimes you can say that, okay, we may stop or something like that, but anyway, you do very great job.
Thank you, Professor Anjali, to give very valuable comment to me. Yes. Okay. Maybe we can go to the next speaker. For the next speaker, Professor Xiang Shou. Professor Xiang Shou will give us about the talk for further diversion treatment for acute ruptures aneurysms. Professor Shou, he is an associate professor in the Shanghai Hospital, Nanyang Medical University in Shanghai, China. Professor Xiang Shou, please give your lecture, please.
Thank you, Professor. I will share my screen. Okay, distinguished Professor Yoko Kato and Professor Itichai, dear friends. I am Dr. Zuo Qiao from Shanghai Hospital and from the Professor Liu Jianmin's team. Today, I'm very honored to join the ACNS webinar and discuss about the FD treatment for acutely ruptured aneurysm. Okay, this is my disclosure. And as we all know that FD has been used in the several types of ruptured aneurysms, including the BBA, ruptured fusiform or dissecting aneurysms, ruptured large aneurysms, and the ruptured very tiny aneurysms. In the latest AHA and ASA guidelines published last year, the recommendation of the FD treatment for ruptured fusiform and BBA aneurysms was class 2. And the FD was also recommended for the ruptured saccular aneurysms, which could not be treated by the coiling or the clipping. And you know that in 2012 AHA guidelines, the recommendation of using FD or regular stent was just class 3. So it is a very big progress of FD or regular stent use in acute stage in the past 10 years. So whether it is effective or safe, I want to discuss several literatures at first about this question. So this is a retrospective study, enrolled six centers and 44 ruptured aneurysms treated by FD. All the aneurysms were treated within 15 days after rupture, and 30% was treated within 24 hours. So you can see that 45% aneurysms located in posterior circulation, and 20% were treated by FD with additional coiling. So it means the 80% with just the FD alone. And in this group of patients, the favorable clinical outcome with MRS 0 to 2 was 45%, and the all-death rate was 18%. The procedure complication rate was 55%. So you can see it was much higher than the regular stent, as other literatures reported. Especially the aneurysm rebleeding occurred in 5 patients after procedure. The rate was 11%. And among the 5 re-ruptured aneurysms, 4 were treated by FD alone. 1 patient was treated by FD with additional coils, although the rate was both 11% in the both subgroups. The reason of the re-rupture in the patient treated by FD with additional coils was actually the FD migration into the aneurysm after procedure. This is another study, included 5 centers and 110 ruptured aneurysms. The mean time from SAH onset to treatment was 3.8 days. It is interesting that in these patients, only 5% patients were treated by FD with additional coils. So the most were still treated by FD alone. And in this study, all death rate was 18%, and the treatment-related complication rate was 45%, which was also very high. Interestingly, there were 3 patients suffered the rebleeding after surgery, and all of them were treated by FD alone without coils. And this is a meta-analysis including 26 studies and 357 patients. You can see 18% of the patients were treated by FD with additional coils. The favorable clinical outcome was 73%, and the complete aneurysm occlusion at follow-up was 85%, which were acceptable. However, the overall complication rate was 24%. It was still high compared to the regular stent, I think. And the ischemic complication was the most common procedure complication with 4.5%. And 11 patients suffered rebleeding in this study. In the rebleeding cases, 82% occurred in the patients treated by FD alone. And half of the rebleeding patients died finally. So how about the FD with the surface modification? Is it safer for ruptured aneurysms? I think the answer is no, as so far. This meta-analysis showed the peri-procedural ischemic complication rate was 20%, and the hemorrhagic complication rate was 8.8%. So there's no difference between using the mono antiplatelet medication or the dual antiplatelet medication. So I think the advantage of the FD with surface modification treatment on rupture aneurysms is not clear. Okay, then I will want to show some cases of the FD use in different acutely rupture aneurysms. This was a BBA, and the aneurysm size was 3.5 millimeter. The distal and the proximal artery diameter was 3 millimeter and 4.2 millimeter. So we used a Chinese domestic FD. It was called tube bridge. I'm not sure whether you have it in Japan or in Thailand. We choose a diameter of 4 FD with additional coils to embolize the BBA. We always use the semi-jailing technique, as showed in the middle picture, to make it safer when we do the procedure. And the immediate result after the procedure showed the aneurysm was totally embolized. And this is another case of BBA. In this case, there was no typical aneurysm, but only the irregular lumen of the artery. So we only implanted an FD into the parent artery because we think it was difficult and it may be not safe to fill coils into the ruptured BBA. Well, this is the healing process of this case. You can see that at 3 weeks after procedure, the aneurysm was still there out of the stent. Actually, at that time, I really worry about this patient. And so we changed the dual antiplatelet medication to mono antiplatelet medication. And the patient was always under the very close follow-up. And at the 3-month follow-up, the aneurysm was occluded. Also with some, you can see with some intimal hyperplasia in the stent. And today, when I reconsidered this case, I think I will maybe will fill some coils along the lumen like a circle and may protect the aneurysm. Maybe it is more reasonable. Well, this is dissection. And for rupture dissection, I think the vertebral artery dissection or dissecting aneurysm are more common. This case is the MCA ruptured dissection. We implanted an FD into the MCA and filled several hydrocoils into the dissecting aneurysm. And in this case, I think it is very important to avoid the coils into the proximal segment of the MCA to make sure that not to affect the lenticular arteries on the proximal segment of the MCA. So this was the immediate result, which was totally occluded. And this is the 6 months follow-up. The patient recovered well with no neurological deficit. Well, and the last case is also interesting, I think. This is a very tiny aneurysm. This patient suffered the SAH and underwent the first DSA in the local hospital, but the doctors didn't find any aneurysm on the first DSA. So the doctors performed the second DSA examination 2 weeks after the SAH onset and found a very tiny aneurysm on the basilar artery, like this picture. And then the patient was transferred to our center. You can see this tiny aneurysm. It was less than 1 millimeter. So I think it was impossible to fill a coil. So we implanted an FD into the basilartery. And on the immediate control after procedure, the aneurysm can still be seen on the late arterial stage. And after 2 weeks, we performed another DSA and found it was occluded. And this is the comparison of 3D reconstruction between the pre-procedure and the 2 weeks post-procedure. Well, we always dedicate ourselves to the stent treatment and FD treatment in acutely ruptured aneurysms in the past years. And we are very delighted that our results and evidence have been included in the latest Chinese and American guidelines. Well, in conclusion, I think FD treatment for ruptured aneurysms still has high procedural complication rate. And as reported, FD with additional coiling may decrease the risk of aneurysm rebleeding. And we should always keep in mind that the prevention of rebleeding is the first target when treating the ruptured aneurysms. So we recommend the FD with additional coils if possible. And so far, no clear advantage of the FD with surface modification was found on treating ruptured aneurysms, and further studies are warranted. And the antiplatelet strategy for FD is in acute stage is also not clear. Well, at last, I must thank Professor Yuko Kato and Professor Iti Chai and all the ACNS members for giving me the opportunity to share our experience from China. Thank you very much.
Thank you very much, Professor Shaw, for your share of the talk. Is very like now we don't have the consensus to use the full diverting stent in the acute rupture. Maybe this is have like benefits from the audience. So any question from the audience?
Hi.
Please, Professor Masamu.
Yeah, I have one question. Thank you for your beautiful presentation. So in your last case, if the degrowth happens, do you place one more flow diverter stent in flow diverter?
Yeah, maybe. Professor,
Maybe.
actually, maybe, yeah. Actually, there are some similar cases.
Mm-hmm.
Because sometimes when we implanted an FD to treat a BBA,
yeah,
maybe 4 weeks, 3 weeks later, you can see it was not occluded, or it may be bigger and bigger. And we have two strategies. One is we decrease the antiplatelet medication, and another is to implant another FD.
Okay, thank you very much.
Yeah, thank you, Professor.
松本先生の意見はどうですか? So, what about your opinion?
Mm-hmm. So I have some cases of the blister-like aneurysm on the basilar trunk region. So actually speaking, I have good result. I can get good results from some cases, but unfortunately, I can't get good results from some. It depends on the cases, not on the strategy.
Okay. Professor, do you always use the additional coils?
If the aneurysm size is 2 millimeter or more big,
okay,
I want to try to coil placement, but there is no evidence to prevent the bleeding.
Yeah. When I read the literatures, I found a very interesting phenomenon that in the Western countries, maybe, and in Japan, maybe, and most doctors use the FD alone, but in China, most doctors choose FD with additional coils.
Okay.
Yeah, no consensus. Yeah.
Consensus.
Yeah.
And how about the tube bridge for the water stent in your country? How about the feeling or efficacy compared with the another brand that we use?
I think it's similar. And do you have tube bridge in Thailand?
No,
Okay.
we don't have in
No, in
Thailand.
Japan. Yeah, no, in Japan.
Okay. Actually, the most difference is that tube bridge is made by nitro metal. Okay, and the pipeline or other evolved something like that. They were made by the cobalt, right? Cobalt and the chromium. So the materials is different.
I know the tube bridge has 48 wires. It's correct?
Yeah, 14.
Okay. If we don't have any question, we will finish about this session. Thank you, Professor Shaw, for your great topic. Okay, thank you very much. Okay, for the next speaker, I would invite Professor Yoichi Morofuchi to give a lecture of the flow diverters in the treatment of large or giant intracranial aneurysm. Now, Professor Yoichi Morofuchi, now he is associate professor in Nagasaki University Hospital. Please, Professor, please give your talk, please.
Okay, so can you hear me?
Yes, I can hear you.
Okay,
I can.
so can you see my slides?
Yes.
Okay, thank you. Hello, everyone. I'm Dr. Yoichi Morofuji from Nagasaki University. First, I'd like to thank Professor Yoko Kato and Professor Ichitai and organizing committee of ACNS for inviting me such a great seminar. Okay. I prepared two topics of flow diverters today. First, how we have changed to select the treatment method for large or giant aneurysm after induction of flow diverters. Second, how we can detect the incomplete occlusion post-flow diverter treatment. Let's move on our first topic. I'm going to talk about the impact of the induction of flow diverters, especially for large or giant aneurysms. As you can see, we have a variety of treatment methods for these aneurysms. In this study, we investigate the evolving trends and issues in treatment selection before and after the introduction of a flow diverter at our institution. Out of a total of 909 cases of cerebral aneurysms treated at our institution past 10 years, 64 cases, 7% with an aneurysm diameter of the 50 millimeter or more underwent treatment. We conducted a comparison between the pre-FD period and post-FD period. There were no significant difference in age, sex, and or subarachnoid hemorrhage status. The predominant origin site was internal carotid artery with 50 cases in this location, 11 cases in the posterior circulation. There were also no significant difference between aneurysm location size between the pre and post-FD period. After flow diverters were introduced, treatment methods dramatically changed. Specifically, 10 cases had surgery and 17 cases chose endovascular treatment. Importantly, all cases of endovascular treatment involved the use of flow diverters. One case that implantation of flow diverter was unsuccessful, subsequent decision was made to occlude the parent artery. Let me show one case during the pre-flow diversion era. The initial period of this study, we followed this treatment algorithm for complex and ruptured aneurysm, especially for cavernous aneurysm. The determination of the bypass type was made based on the result of balloon test occlusion. The unique point of this chart was the confirmative BTO and endovascular ICA occlusion. The confirmative BTO and endovascular ICA occlusion under local anesthesia were planned a couple of days after the bypass placement. This case was a 27-year-old man with a symptomatic left giant cavernous ICA aneurysm. Although the patient was clinically tolerant to the BTO, SPECT showed an asymmetry. 5 days after high-flow bypass with radial artery graft, endovascular ICA occlusion was successfully performed with coils following the confirmative BTO. Next, I will show you the data after the introduction of the flow diverters. This figure shows the treatment selection for large or giant aneurysm performed during the study period. As you can see, after the introduction of flow diverters, the rate of endovascular treatment is increasing, and all but one were flow diverter placement. This figure shows the functional outcomes between pre and post-FD period. There was no statistical difference between them, but as you can see, the rate of the modified Rankin scale 0 is higher during post-FD period. This is a normal successful case of flow diverter. 80-year-old woman with ICA C4 large symptomatic aneurysm. We had waited for 2 weeks until the procedure, since this case was a hemorrhagic onset. Today, flow diverters are widely used and often the first choice for treatment of complex intracranial aneurysm. The procedure of flow diverter itself is not technically difficult. Among the 16 patients who underwent FD placement in this study, no perioperative complications were observed. However, we have encountered 2 cases which needed additional intervention. This is the case of newly aneurysm formation at the distal side of flow diverter placement. The patient is a 61-year-old woman with a symptomatic left large cavernous aneurysm. First flow diverter placement was uneventful. However, 18 months follow-up, you can see 2 aneurysm formation at the distal side of the flow diverter. Based on the expert's opinion, we deploy the additional flow diverter between C2 and C5 segment. The assay 1 year after second FD placement showed the complete disappearance of both original and the newly formed aneurysm. We have found similar papers of treatment trend for the larger or giant aneurysms. I picked up 2 papers. One is from US and the other from the UK. Only 3% of patients were treated with bypass during post-FD period compared to 8% of those in pre-FD period. In a paper from UK, they concluded that with a decline in the incidence of cerebral revascularization surgery, there is a need for centralization of services to allow high standards and outcomes to be maintained. The management of large or giant cerebral aneurysm has witnessed a significant transformation with a substantial shift towards the utilization of the flow diverters. Currently, direct surgical intervention is reserved for cases involving the hemorrhage, bifurcation aneurysms, and thrombosed aneurysms. Cerebral bypass remains also as a very important salvage technique after failed flow diverter stent aneurysm treatment. I'll move on to the second topic, how we can predict the incomplete occlusion after flow diverter treatment. I'm still not sure it is possible or not. The number of the patients benefiting from this expanded indication of flow diverter is steadily on the rise. This is a paper showing the FD treatment outcome from the pooled analysis of 3 large studies. The complete occlusion rate after 3 years of the flow diverter stent in Europe and the United States is reported to be over 90%. On the other hand, a recent report from a single center in Japan shows a complete occlusion rate of less than 80%. The fact that about 20% of cases in Japan lead to incomplete occlusion is a major problem. So we analyzed the FD treatment outcomes at our hospital and examined the factors for incomplete occlusion of aneurysms after flow diverter. We retrospectively identified 46 patients treated with flow diverters. Aneurysm occlusion rate were assessed using the OKM grading scale. This table shows the clinical characteristics. Some cases are overlapped with the first topics. The mean age was 63 years. The aneurysm size was about 13 millimeters. So then the adjunctive coiling was performed in 41% and the post-PTA in 74% and retreatment in 5%. There are the results showing the occlusion rates at 6 months and 1 year. The complete occlusion rate was 65% after 6 months and 75% after 1 year, which is almost the same as the result reported from Japan. Then OKM grade A cases became grade C after 18 months. OKM grade B cases were 3, all with adjunctive coiling. So we retrospectively investigated 3 cases of adjunctive coiling and identified that it was due to poor adhesion of the flow diverters along the microcatheter. Now I'll show 2 representative cases of incomplete occlusion caused by microcatheter for adjunctive coiling. The first case is a 69-year-old woman with a large C2 aneurysm. She presented with a visual disturbance. The size of aneurysm is 20 millimeters. So the initial treatment was a pipeline placement with adjunctive coiling, considered the risk of the aneurysm rupture. However, follow-up DSA 6 months and 1 year later showed that the aneurysm had increased over time and jet formation was observed. This is the 3D image of the FD treatment and the 6 months follow-up. As you can see, there is a residual blood flow along the microcatheter. Although post-PTA was performed in this case, FD adhesion was not confirmed after PTA. We performed the second FD retreatment 20 months after the first FD implantation because of enlargement of the aneurysms. Second FD was deployed within the first FD. However, the enlargement of the aneurysm did not control, and 3 years after the first FD treatment, the patient presented with a delayed aneurysm rupture. We performed the trapping with high flow bypass, and fortunately, the aneurysm disappeared and the patient was discharged with the modified Rankin sleeve. The second case is a 79-year-old woman with a large C5 aneurysm. The size of the aneurysm is 12 millimeters. We performed the pipeline placement with adjunctive coiling. However, a follow-up DSA at 1 year showed jet formation along the microcatheter as in the previous case. So this is a result of our MRI 4D flow analysis. The microcatheter for the adjunctive coiling was implanted in the inflow zone on the 4D flow streamline, suggesting that this blood flow forms the jet. There are many factors for the incomplete occlusion. In this paper, aneurysm size, a Lehman score, and high age, and the presence of the branch, and lack of coils. Our study suggests, however, that the adjunctive coiling has the effect of promoting occlusion rate, but also contributes to the incomplete occlusion. Flow diverter stent adhesion along the microcatheter leads to jet formation. The paper shows the usefulness of adjunctive coiling for medium and large aneurysms. However, our study suggests that the adjunctive coiling may be a factor in incomplete occlusion. The mechanism of the incomplete occlusion by the microcatheter is illustrated in this figure. During FD implantation, the microcatheter for the coiling was jailed, and the FD adhesion could not be obtained. After a few months, endothelialization occurs along the FD, but the blood flow remains in the area of the pleural adherence along the microcatheter, and the jet is formed. As a result, enlargement of the aneurysm may occur. In this case, it is important to obtain FD adhesion in the entry portion of the microcatheter. That is the proximal portion of the microcatheter for the second FD implantation. Flow diverter treatment of the sidewall aneurysms can be quite effective, but 20% of these aneurysms result in incomplete occlusion. Adjunctive coiling contributes to complete occlusion, but residual blood flow along the microcatheter could form jets. So it is important to ensure the FD adherence. Flow diverter treatment has become mainstream for intracranial aneurysm, especially for large or giant, large or giant aneurysms. Nevertheless, the retreatment and including open surgery is needed in some cases. To elucidate the risk factors for residual aneurysm after flow diversion is crucial. So our 4D MRI investigation may be helpful to predict the future residual aneurysm. Thank you for your kind attention.
Thank you so much for your talk, Professor Yoichi. It's really good topics. Yeah. To have some comments from the audience.
先生、いいですか？
はい。
はい。Morobuchi先生、thank you so much for a wonderful talk. Congratulations. So just I want to ask, you switch the high flow vipers, the case. So how we can understand before the treatment of FD? So maybe we should be careful more, consideration more such kind of the indication. And also, is there any preoperative analysis of the hemodynamic will be changed before and after the placement of the flow diverter? Just let us know, please. Because just we put the flow diverter to prevent the future rupture of the aneurysm. Recently, I read the paper. Just put the flow diverter, even the aneurysm is still remain 3 or 6 months. but never rupture that papers. More than 100 analysis, I think. Just let us know your idea, please.
So in the medium size of the aneurysm, so actually, so the almost 100%, we don't have experienced the rupture, but the large or giant aneurysms like vaginal top large giant aneurysm or C2 the ICA C2 the anterior wall the giant aneurysm, that is it's sometimes a problem just to place the FD. Sometimes we cannot control the enlargement of the aneurysms. I showed I presented one case of that. We had to switch to the high flow bypass and trapping.
Thanks so much.
Yes. Yes. Professor Yoshi, for in younger patients, if the patient has the giant aneurysm for the supracranial or basilar tip aneurysm, do you suggest to treat with a flow diverter first, or you suggest to do a surgery like a trapping and high flow bypass? Which one do you prefer for the younger age patient?
So the patient is young, so we recommend the flow diverters because the flow diverters, so the complete occlusion after the flow diverter, it's better than for younger patient compared to the older patients.
Thank you. And for another question, do you have the experience of a perforator infarction after you put like the flow diverter on top, the first one?
So at the first time I was really worried about the kind of like the obliteration of the perforators, but I have never experienced. Well, I don't have much experience about 50 cases, but I have never experienced the perforator infarction or something like that, luckily.
Thank you so much for your answer. Do you have any comments from the audience? If there is no another question, thank you, Professor Yoshi.
Thank you
for your excellent talks. Okay, I will go to the next speaker. This is the last topic that is really quite interesting because it can no one wants to talk about this, but we have the last speaker, Professor Twisak Bunyawas. He is one of the most outstanding surgeon who have lots of experience to use the flow diverters, treat aneurysm in Thailand, and now he is the president of Association of Thai in Interventional Neuroradiology. He will talk about the complications related to flow diverting stent. Professor Twisak, please.
Thank you, Mr. Chairman. Good afternoon to everybody, and thank you for the organizing committee for letting me show our experience in Sirilat Hospital. As you know, no one wants to talk about the complication, but anyway, sometimes I think you need to know from the past. Our data, we have 20 aneurysms, 115 patients treated with flow diverter. So far, we have a major stroke leading to death within 30 days, 3 cases, all of which are large and giant aneurysms. And we have 2 major neurological deficits within 30 days. And the others, we have minor complications like groin complication, in-stent stenosis, or endoleak, which is leaving the aneurysm open, or the cervical ICA dissection, or else. It's about 20 cases. The complications were listed as is. I will talk one by one. The first complication, which is the parent artery occlusion or thromboembolism. A patient presented with subarachnoid hemorrhage. She was discovered of the rupture dissecting VA aneurysm on the left side, which was treated by stenosis coiling at the first time. And then as we follow her, a year later, it seems okay. But 3 years later, just because of her blood vessel is not good, the aneurysm progression, and so we have planned for flow diverter with additional coiling just because the ugly looking vessel. So here before, and then after we put the flow diverter with additional coiling, it looks okay to me. We leave the basilar aneurysm open up just because we don't want to treat all the aneurysm at the same time. We would like to schedule her for further treatment. This is the follow-up. We have seen the aneurysm is progressed by time. So the plan is we need to put the additional flow diverter, and the aspirin was continued. After that, before just we put the flow diverter, she doesn't have any symptoms, but we make the angiogram for the time that we would like to put the flow diverter, and it showed that the left ear was occluded. So it's about 26 months after the first device was deployed. And here, luckily, we have the right vertebral control, so she is okay. She is okay. And when we see the literature, you can see very late thrombosis of the parent vessel can be occurred. This case is dissecting VA aneurysm as we presented. But luckily, our case is okay. But this case, the patient has ischemic symptoms. So the lesson learned, this kind of complication is quite rare, but sometimes we need to advise our patient that it can happen. Next complication is the wire perforation. We have a case with rupture right SCA aneurysm that was partially coiled, and then we schedule her for staging treatment with flow diverter later. Here, after we put the flow diverter from the VA to the right TCA, it seems okay. But after the flow diverter was deployed, this is the run. There's leakage of the contrast at the right TCA, and the CT show subarachnoid hemorrhage. But we must confess that we don't see the leakage until we make the expert CT at the time that we put the stent. So we retrospectively look at the angio again, so we can see the leakage, and then we retrospect to the angio, the live image that the live video that we record. So you can see the first row, the first column, the wire in the occipital temporal branch, which is pointing medial, and on the lateral view it's pointing lower, and another branch, which is parietal occipital branch, pointing upward on the lateral view and pointing lateral on the AP view. So here, the next column is the junction of the vessel. And so you can see the time that the vessel was perfect. The lateral view looking okay. It seems like the wire is in the vessel, but when you look at the AP view, it doesn't follow the course of the occipital temporal branch. So it is perforated. Then we use the balloon to temporarily arrest the fall. And then after the procedure was performed, luckily the bleeding was stopped. And the patient is okay. The lesson learned is that when I teach our fellow, we always teach them that not looking only at the stent, but always look at the tip of the wire during deploy the flow diverter. And also, in case of using an exchange micro wire, because sometimes the flow diverter deployed in the very large aneurysm, you need to use the exchange micro wire. You need to pay attention to the tip of the wire, because sometimes if you move a little bit, it perforates the vessel. And we recommend to use the biplane if you have it. Okay, because only single plane sometimes it's not enough. Sometimes you can see our case, the lateral view follow along the vessel, but the AP view doesn't. Next complication is the stent malposition. We have an ophthalmic aneurysm that was clipped, and when we follow the aneurysm, the aneurysm was growing. So we schedule the patient to have a flow diverter. At the time that the flow diverter was deployed, we doesn't understand that much. The stent was not fully open at the distal end of the stent, but we decided to leave it. And here, at the time of follow-up, so you can see asymptomatic stenosis. The patient is okay. The patient doesn't have any symptoms. But anyway, long-term follow-up. So we followed this patient for 10 years after flow diverter. And it shows, you can see hemodynamic induced by the jet flow because of the stenosis, induced high jet flow to the wall of the vessel. So you can see dilatation of the distal to the flow diverter, and de novo aneurysm occur at the point of PCON and ICA junction here. So this is the complication that we didn't expect. Next patient has that ICA aneurysm, and then we deploy stent, and the stent is not fully expanded. the expert CT showed stenosis at the middle of the stent. This is after the healing process, after the stent was not fully expanded. So you can see the stenosis, which is quite significant. Okay, but luckily the patient doesn't have any symptoms. Okay, so the next case is the incident finding of paracrinoid aneurysm. She has multiple aneurysms, so we decided to do the flow diverter. Here, after the deployment, after we learn several cases that have complication before, so now we don't want to leave it like that. So the distal end is not opposed to the wall like we would like to, and also the proximal end. So you can see here. And if you decided to leave it, I believe that the vessel will be healing like stenosis at this level, and also at the proximal end of the stent. So we decide to correct the stenosis by using wire, but it's not open. Wire manipulation, sometimes it's helpful, but sometimes it's not. So neuroform stenting is another rescue technique. We use neuroform stenting longer than the flow diverter. We deploy the stent, and here after we deploy the stent. Okay, so you can see improvement of the stent apposition to the wall of the vessel after neuroform deployment. So this is the example of rescue treatment. So the lesson learned, to prevent stent malapposition, sizing of the stent is crucial, because if you oversize the stent compared to the vessel diameter, sometimes it's not fully expand. So sizing stent is crucial. And landing the end of the stent, when usually we do planning of the landing zone, we usually like to landing on the straight segment artery as much as we can. And to correct the stenosis or malapposition, sometimes balloon remodeling technique is helpful also, or microcatheter or micro-wire manipulation are also helpful. And if the stent is not well expanded, I recommend don't leave it. Just fix it. Otherwise, the healing will be as I have shown. Leaving the significant stenosis is not good. So next complication is the failed catheterization. Sometimes very big aneurysm or giant aneurysm, we sometimes fail catheterization, and using different catheter or different shaped wire sometimes is helpful, but sometimes it's not. So we have aneurysm that we cannot select, and then we stop and change to another option of treatment like surgery. Here, this case, we have iatrogenic CCF, just because we don't want to lose the case, so we attempt to select, but complication occur. So take home message is that there are other options of the treatment. Sometimes you don't need to be aggressive. And for the option of selecting the normal vessel that you want to go, sometimes shaping microcatheter or even shaping the intermediate catheter is helpful. And don't aggressive manipulate the aneurysm. Puncture site complication. Here is the ultrasound of femoral artery, which has full aneurysm. We almost lose the patient just because this complication is overlooked. And also sometimes it's not only arterial site complication. Sometimes if you get the femoral hematoma or very large pseudoaneurysm, it compressed the vein. So you have both arterial site complication and the venous site complication just because you get deep venous thrombosis of the leg. So which is terrible because you need to correct both at the same time. And the radial approach is an option. Next complication is the delayed aneurysm rupture. We have a patient with supracrinoid giant aneurysm. This case underwent a balloon occlusion test, but unluckily the balloon occlusion test made complication. The patient have ICA dissection. So the patient decided to delay the treatment, and also we need time to allow the healing of the ICA, and the aneurysm is growing, and she refused surgery and she refused balloon test occlusion again. So we do cursive stenting. We correct the ICA dissection, and as it is a giant aneurysm, so we don't want to leave any space inside the aneurysm. So we used flow diverter with additional coiling. So we packed as densely as we could, just because we don't want to have a delayed rupture. But she woke up nicely without any neurological deficit. But next afternoon, it was ruptured, and the patient died. Another case, an elderly male. He has a giant aneurysm, obstructive hydrocephalus. We decide to do flow diverter to the left PCA just because the right PCA is quite big. So we put the flow diverter and also the coil, just because the aneurysm size is very big. And then this is after the operation. The patient is good, so we brought him back 5 days after the operation to make sure that there's no thrombosis, no nothing. So we were very happy at that time. After that, his condition getting worse. The aneurysm growing compared to previous study. So the size is bigger, and also he has a midbrain compression, and then it was ruptured. So delayed rupture of the giant aneurysm after flow diverter, plus or minus coiling cannot be 100% preventable, I would say. So if I have the better treatment option, I will go for it. So not only delay aneurysm rupture, sometimes significant aneurysm mass effect can be occur after stenting. Next is the remote intracerebral hemorrhage. We have a BBA, blister aneurysm, and then we put the stent assist coiling at the first time. And then after that, we put the flow diverter just because the regrowing of the aneurysm as expected. And during the treatment, the patient has cerebral infarction just because of the severe vasospasm. And then we keep on giving him the dual antiplatelet, even though he has infarction. And here, the hemorrhage occurred after days. Here you can see the point of the aneurysm that we have put flow diverter and coiling. There is no hemorrhage next to the aneurysm, but the epicenter of the hemorrhage is, we believe that the cause of the hemorrhage is hemorrhagic transformation. So we try to avoid flow diverter stenting in acutely rupture if possible. And also, even though you don't have the subacute infarction, but ipsilateral limb mode intracerebral hemorrhage can be occur, even though it's not common. Next is a perforator or side branch missing or infarction. We have a cavernous ICA aneurysm here. Put the stent, and here after, so put the stent here, and you can see the distal end of the stent is landed just at the ICA bifurcation. It just so here. After we follow up, the ACA was missing. Just because the flow effect of the flow diverter, or just because of the inflammation around that, we don't know. But here it's after. Comparing between comparing left ICA before and after the operation. And another case, a big basilar tip aneurysm. We decided to put the flow diverter across from the basilar to the PCA. It looks okay. The flow was disrupted. Compare before and after. Immediately after the operation, the patient wasn't wake up well, so she also has left-sided weakness. The MR was done. It showed right thrombic infarction. So the P1 was occluded on the right side. The P1 perforator was occluded on the right side. So the lesson learned is that cover arterial occlusion can be expected, especially we cover the branch that has good cholesterol. For example, we cover the origin of the A1. The contralateral ACA would take over the ACA both sides, or we cover the PCOM. The vertebral basilar system would take over the flow. Okay, that is the common finding. But I would say before you cover the A1, you need to make sure that the contralateral A1 is patent or is big enough. And cover perforator infarction is not uncommon, as we have shown. Next is in-stent stenosis. In-stent stenosis doesn't mean the stenosis of the vessel that's caused by the stent itself that is not fully expanded. But in-stent stenosis means proliferation of the intima, some degree. A case of right ICA aneurysm, again, multiple. Here, oh no, sorry. All right. I think I'll put the wrong one. Sorry. Here is the a patient with incidental paratinoid aneurysm, and we'd like to put the flow diverter across, and here is the follow-up. So you can see the dashed line is the location of the vessel that has stent in. So you can see significant stenosis of the vessel here. Okay. And in-stent stenosis is common, most of which are asymptomatic. And we observe in every stent, every vendor, but some of them are more common than the other. Cover large side branch with a flow diverter can lead to occlusion. Sometimes, most of the cases are asymptomatic, but some of them are symptomatic. And study of the collateral is important before you cover the branch. The last complication is aneurysm persistence. We have aneurysm, ophthalmic aneurysm that has the ophthalmic artery arising from the sac. So at that time, we are afraid of aneurysm persistence, so we added coil before we put the flow diverter. And then after 6 months, the aneurysm persists. There's no occlusion. So we need a long-term follow-up for this case. So side branch coming from the aneurysm is a key factor for aneurysm persistence after flow diverter. And so carefully select your patient. So thank you very much for the chance of of sharing my cases.
Thank you so much, Professor Tavisak, about your talk in every aspect of the communication of flow diverter stent. So any comments from the audience? And from Professor Nakahara, do you have any comments, please?
Thank you very much. No, I don't have any particular comments. It was very interesting and very nice presentation of you. Thank you very much.
Thank you.
So, Mr. President, So thank you very much for your nice presentation, Dr. Kato from Japan. So just you mentioned about the occlusion of the perforators. So you cannot tell. You understand my question?
Yep.
So can we expect the occlusion of the perforators? Because you mentioned about the P1 perforator is occluded in your case. But some other presentation is they do not have any experience of the perforator occlusion. So how do you think about it?
Yeah. As far as we put the flow diverter from the basilar to the PCA, we have several cases that only one has a P1 perforator infarction. I'm not so sure what is the cause or the key factor that explain this complication. But we like to avoid the flow diverter across the basilar if possible. Yeah.
So that is not a good indication.
Yep.
Okay, thanks. Anyway, the demonstration, excellent presentation.
Yes, Professor Kato now, Professor Tuvisang is the Mr. President in Thai.
Yeah.
About neuro intervention.
Yes.
Professor. Yes. And any comments? If
so the question in the Q&A, someone asked about in case of hemorrhage, what is your advice, please? What I don't know. He asked Dr. Ahmad. Oh, his name is Dr. Ahmad. Okay, so at that case, we stop dual antiplatelet. So far we have only one case that has a large parenchymal hemorrhage like that. We stop the antiplatelet and we remove. No. That case we don't remove the hematoma just because his relative refused to do. Yeah.
Okay. That's Professor Kato, do you have another comments or
So I want to ask Nakahara Sensei.
Yes.
Nakahara Sensei, how do you think about the how to say because Thai endovascular treatment is much more advancing in Japanese. How do you think about that? Or equal?
Yes. I'm very impressed with the advancement and the development of the endovascular treatment in several countries. I'm very surprised, and it was very interesting. I think there might be differences between countries and countries, or maybe hospitals and hospitals within one country. So I think it is very important to distribute more technologies and knowledge to the whole country, or maybe a whole area of the Asia.
So how do you think was Mr. President? Can you make some comment? Because the hospital, the country by country, so different the treatment way. So how do you think?
So you asked me, right?
Yeah.
Okay. So I think yes. Different country can have different treatment, can have different strategy, and also in terms of budget, So we have different factors that influence us for the treatment of cerebral vascular disease.
I think it is not good for the patient, I think. So
Yeah.
should be uniform, right? I think, in the future.
Yep.
Maybe Nakahara sensei think the same things, I think. Sensei?
Okay, and maybe today we already finished about the meeting on webinar. So, Professor Yoko Kato, could you make like some speech for closing, because you are the president of the ACNS. So maybe you can, yeah,
So,
Professor, please.
thank you so much. But I'm not suitable person because I'm an open surgeon and not endovascular surgeon. But even though I think that we were discussing at the last moment, so the Chinese doctor, I forgot his name, doctor from Shanghai, he mentioned about some guideline in between China and America, something like that. He showed us on slides. I think maybe in the future should be very uniform. That's very, very important, I think. So it's very difficult. So that he's now I can see his face. So how do you think? I think, of course, some countries very underdeveloping countries. So maybe we should teach or train them. Even though the developed country at least should be uniform, I think. Nakara sensei, how do you think about it?
Yeah, I agree with you. Maybe in the future, international guideline, or maybe Asian
Yes.
guideline, or maybe Asian guideline might be very nice. Yeah, I agree.
At least Asian guidelines should be needed, I think. So I think we learned a lot. So many experts, all neurosurgeon in Chai.
Yes, yours most
Okay.
neurosurgeon,
Oh.
but Professor Anjali, she is a neuroradiologist, interventional neurologist.
Your
Yes.
teacher.
Yes, my
Okay.
teacher.
Okay. So I think in the future, maybe some developing countries, for the moment, I have the two doctors from Bangladesh. So the endovascular treatment is controlled by the radiology department. So I think it's a time to teach and train them to treat the vascular lesion with endovascular. I think it's a time. So maybe gradually we can invade to that, I think, direction. I really appreciate your great lectures, and we studied a lot. Thank you very much. Thank you for organizing the Dr. HHI. A wonderful program.
Thank you.
So you should continue, please. This wonderful webinar.
Yes, Professor.
Thank
you. Thank you, everyone. Goodbye.
Hi.
Thank you very much. Goodbye.
Thank you.
松本先生、ありがとうございました。諸藤先生、ありがとうございました。
Thank you.
お疲れ様でした。Bye, the HHI teacher.
はい。ありがとうございます。
ありがとうございました。
はい。ありがとうございました。
失礼します。